In this case, we use some narcotics, some tranquilizers, and in the form of inhalation, there is nitrous oxide, methoxyfluorine, enfluorine, isofluorine. And as we talk about the regional, just like epidural, spinal, and pudendal block, and the paracervical block. These are the regional intervention of the anesthetic agents. Other than this is the psychoprophylaxis and the breathing exercise. These are the non-pharmacological use where there is no any medications are used. Simply, this is the maneuver that support the patient to relieve the pain during labor. There is hypnosis, there is TENS, acupuncture, hydrotherapy, electroanalgesia and audio analgesia and many more, massage and everything. I will talk in later on. Okay, thank you. Let me give some time. These are the list of the systemic analgesia. Everyone knows about the pethidine, fentanyl, remifentanil, tramadol, and the morphine. Other than the inhalational antarox, everyone knows this is the combination of the nitrous oxide and oxygen. And there is a patient-controlled inhalational analgesia. Everyone knows about the epidural anesthesia, spinal, combined, or subarachnoid blocks are there. If, inhalation, the Antonox is most commonly used. There are the neuroaxial block, epidural anesthesia. There are short-acting, long-acting. We use through the catheter. These are the methods how to use this local anesthesia, spinal anesthesia, epidural anesthesia. There is some paracervical block that is given in the stage 1. Their action is lasted for 2 hours, but there is some disadvantage also, like fetal bradycardia and lidocaine toxicity. There are some side effects. Everyone knows there is an hypotension, local anesthetic toxicity, allergic reaction. There is some high and total spinal anesthesia sometimes, neurological injury, spinal headache, and fetal bradycardia also. So, if I'm talking the non-pharmacological use, so in this list, there is a Lampage technique and the breathing exercise. In the Lampage technique, what we do, we just counsel the patient. We just relax the patient, and during the antenatal education of the patient about the physiology of the childbirth. Dard hoga, usse tum maan ke chalo, sharir mein there are so many pain, you have to accept everything. And we have to counsel the patient, and we have to discuss about everything. These are the breathing exercise. We ask the patient in early level, take deep breathing. Toward the end of the stage of the first, there is a rapid breathing, and at the time of the child bearing down, hold the breathing. These all maneuvers helps in the supporting labor pain. Hypnotherapy is that there is an Mongan method known as the hypnobirthing. And in this case, this shorten the labor, reduce the pain, reduce the need for the intervention, and there is high Apgar score. So baby having no any post-delivery complications. There is TENS. TENS is the transcutaneous electrical nerve stimulation. In this, what we do, there is a handheld controller and 2 sets of the fine leads at the 4 sticky pads, and these are applied on the back. The machine gives a little pulse of the electrical energy, and that reaches your skin via the lead and the pad. And the pulses may giving rise to tingling and the buzzing sensation depending upon your setting. And this stimulates the release of the endorphin, control the pain
Nilu,
via
conclude.
the gate control.
Nilu, conclude it. Dr. Nilu.
This is the eclotherapy, this is the acupuncture, and acupuncture everyone know there is some sensitive point where we use it, and some sterile water, sterile normal saline is injected at this position, and the water birthing, पानी के अंदर में delivery कराते हैं batting tub में, that is a very good way of reducing the pain during labor. And there is again water therapy, endorphin, everyone knows that it is very important that relieve the pain. Anyhow, we have to release the endorphin. And music, good music also support the relieving the pain, and the touch and massage also having a supportive role. These are the very advantageous effect of the non-pharmacological method. The take-home message is the painless delivery nowadays is very demanding, safe and effective methods. And every clinician should know the proper training how to deliver such patient. The center should have an optimal activity trained staff and delivery room set up to manage the case. Neonatal care must be available in the center to manage the baby delivered, and the patient and attendant must be consulted properly about the everything before planning for normal delivery. This is the happy ending. The delivery of the infant into the arms of the conscious and pain-free mother is one of the most exciting and rewarding moment in medicine. Thank you for patient hearing.
Thank you, Neelu ma'am. It was really a very nice presentation, and we all know it needed a human touch, and that you have given that. And women in labor should always be offered which method to use. It is her choice, pharmacological or non-pharmacological, and we have to go far in this field because we need more research, like what are the effects of these methods on the interaction of baby and mother, on the breastfeeding and sense of the mother after these applying methods. So thank you very much. It was really a very nice presentation.
Next speaker is Dr. Pratibha. She is going to deliver her lecture on rational use of antibiotics in obstetrics. We are very thankful to you, Dr. Pratibha. She has come all the way from Imphal. We welcome you at Patna. Now, dais is yours.
Good morning to all, respected chairpersons, colleagues, and my dear friends and juniors. I would like to first of all thank the organizing committee of the Labourcon and the Patna Ops and Gynae Society especially for inviting me and giving me the opportunity to present on this talk. Thank you all. And I'll be speaking on the rational use of antibiotics in obstetrics. So we all know about the antibiotic, how commonly it is used. It's one of the most commonly used group of drugs, and nowadays it's a global problem because of the antimicrobial resistance, because of the so commonly used drug. And it constitutes about 50% of the hospital expenditures, and there are various studies that because of the high incidence of inappropriate use in all over the world. Nowadays, lots of guidelines in every societies, in every countries worldwide, including World Health Organization, ICMR, different guidelines are coming up because for the surgical antimicrobial prophylaxis, for the quality improvement initiatives. In India, the antibiotic is in India, it is the largest consumer of antibiotics in the world. Antimicrobial resistance is also very high, especially E. coli. It constitutes 12 to 59%, and also about Klebsiella and other various organisms. The frequencies of the antibiotic use in hospital at any point of time, it's about 35 to 50%. Such is very high incidence. Is it really necessary? What is the most appropriate? What dose, frequency, route, and duration? Is the treatment effective? We have to ask the question. That's the rational use of the antibiotic. WHO has given these definitions that rational use of antibiotic means that we are giving patients is receiving the appropriate dose for the clinical needs in doses that meet their individual requirements for an adequate period of time and at the lowest cost to them and community. Nearly half of the medications are irrationally dispersed, prescribed, or sold. and we have to check it for avoiding the emergence of resistance, to avoid unnecessary increase in the cost in the hospital expenditures, and also to avoid the adverse effects on the patients. Only these, for the treatment of bacterial infection, it should be used. Not all fevers require these antibiotics. Not all infections are due to bacteria, that everyone should know, and no evidence that it will prevent the secondary bacterial infections in patients with viral infection. But most of the doctors, most of the pharmacies and over the counters, everyone prescribe the antibiotics. The golden rules of prescribing antibiotic is that we should remember the microbiology. Eye indications should be evidence-based and should be the narrowest spectrum we should prescribe, and those should be appropriate and minimize the durations of the therapy, ensure monotherapy in most of the cases. There are different antibiotic uses for prophylactic, therapeutic, empirical, and definitive therapies. And the therapy of the antibiotics should be disease-based, durations, and whether it is for prevention or for definitive treatment. Prophylactic, as we all know, it's an adjunct to and not a substitute for the good surgical clinics. There are different benefits. The infections depend on the durations of the surgery also. This one of the studies shows that when it's only 0 to 2 hours of the surgery, then the infection rate is lowest. We can see that only 0.6%. So, at present, cephalosporins group is one of the first choice because it has a low allergic reaction also and has good profile and long half-life. Preferably for surgical prophylaxis, it is advisable to give IV within 60 minutes before the skin incisions. Single dose, 1 gram. If the weight is more, then we can give up to 2 gram. Additional doses may be required if it is more than 3 hours of durations of surgery, or if the blood loss is more than 1.5 liters. Further doses may be added if required. Prophylaxis of the cefazolin is highly recommended by different societies and different guidelines. Alternatively, if there is allergy, we can switch on to clindamycin or erythromycin. This is one of the most commonly used prescribed by different guidelines. So coming to this obstetrics part, that is the cesarean section, as we all know, in the pre-incision, it's preferable that we should give the broad spectrum antibiotics before, it is better to give post-clamping the narrow group also. Then surgical antibiotic prophylaxis prior to infection is very much useful to prevent infection as well as morbidity, that has been proved by the different meta-analyses as well as by the RCTs. Operative vaginal delivery, insufficient data whether to give antibiotics or not. Relative inductions, there is a relative inductions in the infectious morbidities. It's taken as the level 2 evidence for giving the antibiotics. Uncomplicated vaginal deliveries, again optional. Some give prophylactic for preventing the group B as streptococcal prophylaxis, that ampicillin prophylaxis can be given in uncomplicated, that is optional. Complicated deliveries, that is the level 1A is there for giving antibiotics, so we may consider preferably within 30 minutes we can give ampicillins, or added can be gentamicin can be added. Other, if allergic, we can switch on to vancomycin. Postpartum dilatation and curettage for RPOC, insufficient data whether to give, but there are different options. There are lots of observational studies, but no RCTs. Premature rupture of membrane, definitely there are that ampicillins 2 gram followed by 1 gram, 4 to 6 hourly, 48 hours followed by oral amoxicillin, that is prescribed by even by ICMR guidelines. Preterm labor with membrane, that were still optional. Reduction in maternal infections may be there, but no benefit or harm for the neonatal outcome. Still, this regarding antibiotic in preterm is again not getting the level 2 or 3. Sorry, very sorry. Regarding the perineal lacerations in the third and fourth degree, we have to give the single dose antibiotic, preferably broad spectrum antibiotics is level B, evidence is there. Cefotetin 1 gram IV, we are getting at present level 1B as per the Society of Obs and Gynae Society of Canada. ICMR 2017 advised that accordingly ampicillin 2 gram. UTI still we can advise for oral, one of the most common obstetric problems, nitrofurantoin is the choice. Choriomyelitis also an antibiotic is you have to prescribe. Amoxicillin along with that metronidazole has to be advised in the choriomyelitis. Obstetric sepsis, depending on the severity, if it is severe we can switch on to IV piperacillin tazobactam, TDS or cefuroxime along with the metronidazole. Puerperal sepsis, infected CS and perineal wounds, that obviously we have to give antibiotic. 5 rights we have to remember, whether we have to remember the right patient, right drug, right time, right dose and right route. The take-home message is that CS we have to prescribe, obviously, that's the we are getting at present the highest level, that is the level 1A for giving antibiotics. The choice is the first generation cephalosporin. If allergic, we can switch on to clindamycin or erythromycin. Ideally, 15 to 16 minutes prior to skin incision. Third and fourth degree, we are getting the level 1B. If the hours of surgery is more than 3 hours or the blood loss is more than 1.5 gram, then we have to get 1.5 liter additional dose of antibiotic has to be given. Morbid avicity, then we have to consider for giving additional dose. Opinions depend on the different authorities. Encourage the staff for continuous educations and update of the scientific publications regarding the antibiotic prophylaxis. And with this, thank you all, and I welcome all of you in the coming East Zone Foxy UVA at our Imphal. Thank you.
Congratulations, Dr. Pratima, for your nice presentation. Take-home message is clear. Congratulations.
I have a question, Dr. Pratima, that as you have told about the amoxicillin clavulanic acid used as an antibiotic, I have, as far as I know, that it should be avoided in the 3rd trimester of pregnancy as it leads to necrotizing enterocolitis. Is it so?
No, as different guidelines has given different little bit. So the latest one that they have into after the 2009, that ACOG, they have the, earlier it was what you have said that it was to be avoided. After the AICOG, the latest guideline after the 2009, they have corrected and they have said you can give.
Okay. Okay. Very nice presentation and nice topic was there.
Very nice presentation, Dr. Pratima. Thank
thank
you
you.
very much.
Thank you.
Next speaker is Dr. Indra Prasad. She is an associate professor, AIMS Patna. She is going to speak on anticonvulsant. You can talk.
Good morning all. Though topic is too exhaustive and it was a very broad topic, anticonvulsants, and only 8 minutes have been given to me, so I'll just quickly give a little overview on what is new about anticonvulsants. And before that, of course, we should know the most frequent found major neurological disorder in pregnancy is epilepsy. 0.5 to 1% is the prevalence, and risk of death is 10-fold in pregnant women with epilepsy. So therefore, we must be aware of how to deal with women who are already on anti-epileptic drugs or whom we want to prescribe. So before that, a little bit of what are the types of epilepsy. It can be depending on the clinical presentation, we already know it can be GTCS or focal seizures, or according to pathogenesis, it can be primary epilepsy, which is seen in 30% cases, and mostly it is secondary epilepsy, as we see in pregnant women like eclampsia, which is the most common cause for secondary epilepsy. So there are various other reasons like intracranial mass lesions, antiphospholipid syndrome, apart from eclampsia. TTP, thrombocytopenic purpura, posterior reversible leukoencephalopathy, stroke, subarachnoid hemorrhage, drug and alcohol withdrawal, hypoglycemia, hypocalcemia, infections, post-dural puncture, and gestational epilepsy. So whenever women comes throwing fits in emergency, we should not only think of eclampsia. Sometimes they don't fit, BPs is normal and all. So we should have other things also, and maybe we need a CT or MRI to diagnose at that time. Certain other conditions which mimic seizure disorders are pseudo-seizures and syncope. Pseudo-seizures have prolonged repeated seizures without cyanosis, and they have resistance to passive opening. Downgoing plantar reflexes are there, and persistence of a positive conjunctival reflexes. A few things that we can help us to differentiate. And syncope is just associated with cardiac arrhythmias, and sudden vasovagal syncope can also happen. So coming to my topic, which was anticonvulsant, it was more like a pharmacological topic. So there are various generations of anti-epileptics, first generation, second and third generation. So just I wanted to put this on the slide to write this, that carbamazepine and valproate are the first drug for focal and generalized seizures. Like medical people, they would like to prescribe carbamazepine and valproate. And for us, valproate is very, very bad. So that is why we will find people on valproate or carbamazepine. And therefore, we need to do certain things that I will just talk about in next slides. And several other new anti-epileptic drugs, which according to medical people are add-on therapies and not the basic drugs, are recommended for focal seizures. But those are the ones who are safe in pregnancy that we will just discuss. Now, anticonvulsants, why they are culprits? Because during pregnancy, they can result in congenital malformations, pregnancy losses, growth restriction, impaired postnatal development, behavioral problems, and even fetal anticonvulsant syndromes. So why are we so much concerned? Because of the increased seizure frequency that can happen to a woman who is epileptic during pregnancy, because of the subtherapeutic anticonvulsant levels and the lower seizure threshold that happens in pregnancy. The other thing is that because of the anti-epileptic drugs that she's on, there is higher risk, as I just told you, of congenital malformations. And but those women who are not on any drugs, their fetuses are obviously not at risk. So epilepsy per se is not bad, but the anti-epileptic drugs which we are prescribing are very, very bad. So why is there increased seizure rates during pregnancy? Because of increased nausea, vomiting, decreased GI motility, use of antacids that diminishes drug absorption, pregnancy hypovolemia offset by protein binding, induction of hepatic plasma placental enzymes, increased glomerular filtration rate, and women discontinue medication on their own. They feel that they are teratogenic, and then they start throwing fits. So pregnancy-related sleep deprivation can also cause a seizure, and hyperventilation and pain during labor can precipitate seizure. Now, how anti-epileptics cause teratogenicity? There are three mechanisms of action. One is that they form intermediate oxide metabolites which are embryotoxic. So those free radicals, they bind to the proteins, nucleic acids, and interfere with DNA, RNA synthesis, and those result in perinatal death. The second is that it induces folate deficiency, and up to 90% reduction in serum folate levels can occur, and that leads to teratogenicity. And third is a genetic predisposition that causes decreased epoxide hydrolase activity, which can also cause malformations. Now, these are the teratogenic effects of various drugs, and we can see that it's only the newer ones like topiramate and the levetiracetam which has less lesser risk of malformations. Otherwise, the above valproate, phenytoin, phenobarbital, carbamazepine, they're all very, very teratogenic. As far as the pharmacokinetics, just because my topic is like pharmacology, so I just thought that this slide needs to be there. Why it is important is that certain drugs are slowly absorbed, certain drugs are rapidly absorbed, mostly are hepatic. They go through the liver during metabolism, so that first pass metabolism, they induce enzymes, so those things come into play. Okay, so we'll just get into the drug interactions. And what are the common side effects of anti-epileptic drugs? Okay, so these are the like nystagmus, ataxia, hirsutism, gingival hyperplasia, megaloblastic anemia. They will happen in the mother. But fetal, as we said, that teratogenesis, carcinogenesis, coagulopathy, hypocalcemia can happen because of phenytoin, and this we also know by Haddon-Toyen, fetal Haddon-Toyen syndrome. Then carbamazepine also similarly can cause craniofacial neural tube defects. Valproate also causes neural tube defects and skeletal craniofacial defects. And lamotrigine has a certain role in oral cleft lips. Okay, so these are the side effects. Now coming to the newer anti-epileptic drugs: topiramate, felbamate, oxcarbazepine, gabapentin, vigabatrin, and lamotrigine. These are the newer anti-epileptic drugs and much safer in pregnancy because they don't have anti-folate mechanism, no arene oxide metabolites, no effects on the cytochrome P450 enzyme system. So they are eliminated from the body via kidneys, not from the liver, and so they are free from the first pass metabolism. So these are the drugs which are better for pregnancy, but their control over the seizure is less. So therefore, generally, they are not prescribed as the first line in non-pregnant women. But then we can switch to them in case we have a seizure control. Well, a few slides on just managing a woman who comes with on anti-epileptic drugs. Our major goal will be seizure prevention, treatment for nausea, vomiting, prevention of seizure-provoking stimuli like pain during labor, nausea, vomiting, and ensuring that she takes the medication, medical compliance, and anticonvulsant should be maintained at the lowest dose with seizure control. So starting with the preconceptional counseling, which should be done at least 3 months before pregnancy, and all the anti-epileptic drugs should be reviewed. She should be given 5 milligram folic acid and should be continued throughout the pregnancy. And in case she is taking sodium valproate and very at high risk of seizures, then maybe we have to continue with the slide is not moving. Is it freeze? Or okay, fine. So sometimes we need to even continue with valproate, so we can decrease the dose. As I just the last point here I have written that we can go for a modified release valproate preparations, which lowers the peak concentrations and decreases the teratogenic effect of the valproate. All right. So then antenatally, all the in the scannings which we need to do for the congenital malformations. Obviously, we have to be more vigilant in this case where we have the anti-epileptic drugs. All right. So coming to intrapartum management, as I said, pain during labor can precipitate, and 1 to 2% women have this seizure within first 24 hours of postpartum period. So risk of seizures increases around the time of delivery, and she should continue to take the anti-epileptic drugs even during labor, and sometimes we may have to give parenteral preparations in case she's not able to take the oral ones. Pethidine should be avoided, and in place of pethidine, it's better to give dimorphin during for pain relief. And of course, as we already had a lecture on pain relief, epidural analgesia is much advisable in women who are on anti-epileptics, these seizure disorder. This is just a slide to show how IV we can give. We can give IV lorazepam, diazepam, or clobazam for seizure control during labor. All right. So coming to postnatal management. The neonates born to women taking hepatic enzyme-inducing drugs, they are offered 1 milligram intramuscular vitamin K. Why? To prevent the hemorrhagic disease of newborn. And breastfeeding should be encouraged in women. It's not that they are, it is contraindicated, so that is another thing. But most of the anti-epileptic drugs are secreted in breast milk, but the amount is very less, except the labetragene, which is, and phenobarbital, which is secreted in little higher amount, and fetus can show some withdrawal symptom, maybe sleepy, and so in that case we have to they need to keep feeding them, and the dose can be then adjusted. And the women are at a little higher risk of postpartum depression, those who are with seizure disorder. Just last slide on contraception, that because our anti-epileptic drugs are hepatic inducers, and therefore we have to be all the hormonal contraceptive pills will not work much. So the best ones are either Depo-Provera, medroxyprogesterone injections, or the intrauterine system like Mirena, which can be inserted. Now coming just to take home messages, that all women receiving anti-epileptic drugs should receive pre-pregnancy counseling, folic acid 5 milligram daily. Most of the drugs are teratogenic, so lower risk is with monotherapy. Valproate is associated with impaired neurodevelopment, reduced IQ, and risk of autism spectrum disorders. Screening for congenital anomalies have to be done, and breastfeeding should be encouraged. So, drug of choice, therefore, it is important to exclude all the secondary causes of seizure, not obligatory to treat one isolated primary seizure. If treatment is required in pregnancy, lamotrigine or carbamazepine is appropriate for partial seizures, and levetiracetam for primary generalized epilepsy, desirable to avoid valproate during pregnancy. Thank you so much. Sorry for rushing it. Actually, time was very, very less for such a broad topic. Thank you so much.
Ma'am, mic is not on yet. No, ma'am. Next, we are done.
Huh? This is last one. Thank you, Indra. Very well explained. And you have very well explained all about the drugs which are used during pregnancy, during labor, post-labor. Very nice presentation. Thank you.
All right, with this, let's have a big round of applause for our chairperson and all the speakers. You all please come forward. A quick view on the CVs of our chairperson. I would like to show one by one. Dr. Hema is here. Ma'am, just 1 minute, I'll just show. Dr. Chanchal. Dr. Kumari Mamta. And Dr. Sandhya Kiran. So thank you so much for chairing the first morning session on Sunday morning. Thank you. Let's come for group one. Dr. Zarina, can we just hand over their certificates? Okay, sure. Thank you so much. We'll move forward for the session 2, which is lectures on between 9 to 10:30. Special conditions in ops. We got 2 chairpersons who will be coming. I'll be inviting them. Dr. Kamudini Cha. And Dr. Savita Rumta. I request the chairperson to now please invite the first speaker.
Thank you.
A very good morning to everybody. Dr. Himali is an old acquaintance of ours. I was in DMCH when she used to come as an external, and she is very knowledgeable. And she at the All India Institute of Medical Sciences, Patna, and she is the head of the department there. And she has many publications, and she's
Thank you, madam. Thank you so much.
in teaching. And she is a down-to-earth person with excellent knowledge. And she's heading the AIMS team of Ops and Gynae. Her topic is breathlessness in pregnancy. So
Good
please.
morning, everybody. Thank you, Chairperson. I'll be talking about breathlessness in pregnancy. I bring you greetings from my institute, and I'll be talking about patient concerns during pregnancy, physiology of respiration during pregnancy, some situations requiring attention, respiratory emergencies during pregnancy, and of course some take-home messages. So what are the patient concerns during pregnancy? Is shortness of breath during pregnancy normal? Does shortness of breath hurt the baby? These are things that the patient thinks about and asks us. What causes shortness of breath during pregnancy? How to ease shortness of breath? Can breathlessness in pregnancy be prevented? When to seek medical aid? This is very important. And how long will shortness of breath last? And how to deal with it during pregnancy. So is shortness of breath during pregnancy normal? Yes, it is common, especially in the 3rd trimester, also sometimes in early pregnancy, and if it is due to physical strain like climbing upstairs, then it's generally harmless. Does shortness of breath hurt the baby? Well, it does not harm the baby because oxygen is supplied to the baby through the placenta, and deep breathing supplies the fetus with oxygenated blood. What causes shortness of breath? In the first trimester, as we remember from physiology, hormonal changes occur as the body adapts. Progesterone allows the body to absorb more oxygen. The excess level of carbon dioxide is breathed out, and breathing is more deep. There is increase in blood volume by 50%, so the heart works harder. In the second trimester, progesterone stimulates the brain to increase the number and depth of breaths so that more oxygen is absorbed. Capillaries in the respiratory tract are small, so the feeling to take deep breaths. So there's a feeling to take deeper breaths. In the third trimester, the diaphragm moves upwards by about 5 centimeters, restricting the space to expand, and also if the head of the baby is unengaged or if the amniotic fluid is increased, then this problem is more. So when to consult the doctor? This is very important, and this is something we should counsel the patient. In case of underlying conditions like asthma, anemia, if there are complications of the heart or the lungs, severe breathlessness with rapid breathing, chest pain or palpitation, chest pain when taking deep breaths, when there's a bluish tinge on the lips and the fingertips, giddiness after activity, and difficulty in breathing on lying down. So we should counsel the patient that although some amount of breathlessness in pregnancy is normal, but when any of these conditions are present, then she should consult the doctor. How to ease shortness of breath during pregnancy? So we can counsel the patient to sleep with the head elevated, maintain proper sitting posture, take deep breaths and be relaxed, avoid fatty and excess sugary foods, engage in safe and mild exercises. Between work she can take rest and change posture frequently. Then another thing is, why is it hard to breathe at night? It could be due to disordered sleep breathing. So this is a consequence of pregnancy-related changes in the respiratory system and because of maternal obesity. So sleep disordered breathing actually is a spectrum of abnormal respiratory events. There's habitual snoring, increased upper airway resistance, obstructive sleep apnea. Obstructive sleep apnea, there are repetitive episodes of partial airway obstruction during sleep, which lead to intermittent hypoxia and poor quality of sleep. The diagnosis is by polysomnography, and there are risk factors are the physiological, hormonal, mechanical, cardiovascular changes in pregnancy. Anatomical narrowing of airway, which causes increased resistance of the respiratory system, and increased levels of estrogen and progesterone, which induce capillary engorgement, hypersecretion, and mucosal edema of the upper airway. So the dimensions of the nasopharynx, oropharynx, and larynx are reduced. Pregnant women with larger neck circumference and higher BMI are more symptomatic for sleep disorders. So what is the management? There are no specific pregnancy-specific practice guidelines. Some medical devices like CPAP, oral mandibular repositioning device, lifestyle modification, medication, and of course, as a last resort, upper airway surgery can be resorted to. So now taking you back to your physiology days, if you recall, functional changes in the respiratory system during pregnancy. There's marginal increase in the respiratory rate, tidal volume and minute ventilation increase by 30 to 40%. Functional reserve capacity and inspiratory reserve volume decrease by 20%. There is maternal hyperventilation due to the action of progesterone on the respiratory system. So all these are protective measures to prevent exposure of the fetus to high levels of carbon dioxide. So there is alteration in blood gas, which is common. The partial pressure of oxygen increases above 100 millimeters of mercury. The partial pressure of carbon dioxide decreases to 27 to 32 millimeters of mercury, but the pH remains normal. Renal bicarbonate excretion increases, and dyspnea is a common symptom because of low partial pressure of carbon dioxide and elevation of the diaphragm. Now this is a picture from one of the undergraduate textbooks. We find that the total lung capacity decreases. We also find that because of elevation of the diaphragm, the residual volume has decreased and the functional residual capacity has also decreased, while the inspiratory capacity has increased, and but the vital capacity and the inspiratory reserve volume, they remain the same. This is almost the same thing. Okay. Now here I just want to emphasize, as we can see, the alveolar ventilation, the minute ventilation, and the tidal volume, they increase progressively during pregnancy, while the respiratory rate increases till about 20 to 24 weeks of gestation and then plateaus. I'd like to just talk about a few respiratory emergencies during pregnancy. Just to name a few: respiratory failure in pregnancy, acute respiratory distress syndrome, acute lung injury during pregnancy, ventilatory failure during pregnancy, severe pneumonia during pregnancy, pulmonary edema either because of eclampsia or because of beta mimetics, pulmonary embolism, amniotic fluid embolism, and of course the latest kid on the block, COVID-19 infection. So the common thread among all this is breathlessness. Of course, it's not part of my talk because it's very exhaustive. So what to do when we have such conditions? Special consideration should be given to oxygen delivery to the fetus, determined by maternal cardiac output, hemoglobin, oxygen saturation, and oxygen consumption, that is the metabolic demands of both the mother and the fetus. This is significantly increased during labor and if the patient is undergoing cesarean section. All these should be considered in decision making. A multidisciplinary approach for management is necessary, and yes, here I'd like to tell you that in my institute, I'm very, very lucky that we have the kind cooperation of all the departments, the pulmonologist, the physician, the anesthetist, the nephrologist, cardiologist, gastroenterologist. So I think in that way I'm very lucky. So we're able to manage all these patients. So how does this patient present? They present with tachypnea, fatigue, hypoxemia, carbon dioxide retention, alteration in mental status, and abnormal chest imaging. So what are the principles of management? Patients with severe airflow obstruction, there is bronchodilation. Non-invasive ventilation should be tried if respiratory rate is more than 40 breaths per minute. If there's no improvement with non-invasive ventilation in about half to 1 hour, then these patients require intubation. NIV is effective in obstructive hypoxic disease, and when there is hypercapnia or there's high pressure pulmonary edema, which may even be beta agonist induced, and high failure. So all these conditions we can try non-invasive ventilation ourselves, but if the patient requires intubation, we definitely need the help of the anesthetist. And of course, NIV has a high failure rate in pneumonia or in acute lung injury. So intubation, as I mentioned, is indicated for refractory hypoxemia and shock. Intubation, we must remember, is difficult in pregnancy, but it maintains an adequate maternal cardiac output and oxygenation, higher maternal oxygen saturation, that is more than 95%, or a partial arterial pressure of oxygen more than 67, favors optimal oxygen delivery to the placenta. Oxygen consumption should be minimized by ventilatory support, and of course it is most important to diagnose and treat the cause of respiratory failure. These are just some pictures this is a pregnant woman at 31 weeks of gestation with acute respiratory distress syndrome. She underwent emergency cesarean section and was put on mechanical ventilation, and this is the same patient on discharge on postpartum day 11. So if you compare the two lung pictures, you can see how much help we can give to the patient. There's another lady with respiratory distress following, this is because of amniotic fluid embolism, as you can see, and you see this lung just 48 hours after mechanical ventilation. So we can do a lot to support these patients. It's not as if we can do nothing. These are just some case scenarios. We're not going to discuss these because this is how you get patients. And then the first thing we must remember is how to give ventilatory support. So just to summarize, shortness of breath due to exertion is normal during pregnancy unless associated with a medical disorder. Pregnancy-related dyspnea is due to anatomical and hormonal changes that occur to accommodate the growing fetus. Pregnant women should adopt good posture and sleeping positions. The incidence of dyspnea during pregnancy can be reduced by staying hydrated and avoiding strenuous activities. These are all what part of the counseling we should give to the patient. Breathlessness with severe chest pain, fatigue, blue discoloration of skin, dizziness, and fever need immediate medical attention. Significant changes occur in the anatomy of the respiratory system with pulmonary functions during pregnancy. There is hyperemia and edema of the mucosa of the respiratory tract. Mucus secretion is increased. Chest expansion is increased due to relaxation of the ligaments attaching the ribs to the sternum and upward displacement of the diaphragm by about 4 to 5 centimeters. Low maternal partial pressure of arterial carbon dioxide leads to chronic respiratory alkalosis. Oxygen consumption is increased. And pregnancy imposes a significant challenge in the management of patients with respiratory failure. Providers need to consider both maternal and fetal well-being at all stages of the disease. An understanding of the normal physiologic, circulatory and respiratory changes of pregnancy is important in managing such patients. Thank you.
Thank you, Dr. Himali. That was an excellent and very crisp presentation. You started right from the changes in the physiology in pregnancy, which may lead to the changes in the tidal volume, and the respiratory efforts are increased. And at the same time, you discussed about the pathological conditions like ARDS and how it was the chest X-rays you demonstrated after treatment, how they improved. And the sleep apnea, now that is an important thing, the obstructive sleep apnea, because now you have sleep apnea clinics in which they have those devices which you mentioned, which help because that improves the oxygenation. And that is needed, and especially when patients come in an acute condition with chest pain and breathlessness, you have those not only the respiratory causes, but causes like maybe cardiomyopathy, especially in preeclampsia patients. They may be because of other cardiac causes like myocardial ischemia. So they have to be investigated on those lines also. And about the intubation, yeah, that is important because it is difficult in pregnancy. You always need an anesthetist for that. And of course, a multidisciplinary treatment that you advised for ventilation. Thank you so much. That was an excellent talk.
Thank you, madam. And I also wish to thank the organizers for inviting me. Actually, these people keep us in such a rush that I forgot in the beginning. Anyway, I'm glad I finished on time.
The next speaker is none other than Dr. Usha Didwania. She is a very knowledgeable teacher and everyone's favorite here, and we have heard her a lot of times in the webinars. And she has been the past president of the Patna Menopause Society, and she's the advisor in Genetic and Fetal Medicine Committee also, and she has presented many papers. So we now would like to hear from her about instrumental delivery.
Good morning to all of you, and it is a very important topic, instrumental delivery. I am thanking the organizer to giving me this topic for today here. Instrumental delivery, if you talk about instrumental delivery, it is considered an instrumental vaginal delivery, although forceps and ventouse are used during cesarean section also. And the forceps was invented as back as 1735 by Chamberlain, and since then innovations have been made till the obstetric forceps and Keylander forceps and Wrigley's forceps had come. And vaginal vacuum delivery first occurred in 1705, and after 1950 it is in regular practice. It is also known as assisted birth when forceps or ventouse suction cup are used to help deliver the baby. The incidence worldwide is 6 to 12%, and in different countries and in different states of the country has its own incidence. In India, 2.7 to 5% as of now. It is used to assist birth vaginally at late second stage when allowing time for normal birth is less safe. The choice of instrument depends on careful assessment of clinical situation and meticulously selection of the patient. Clear communication with patient should be done and written consent should be taken. These are the types: vacuum, kiwi and forceps. And in late second stage, instrumental delivery is done mainly in the interest of fetus, when fetus is compromised. And in maternal, if prolonged second stage of labor is there and no progress for 30 minutes even after adequate pushing, maternal exhaustion, previous LSCS or prolapse repair, and any other medical indication to cut short. These are the indication to cut short of second stage of labor, but no indication is absolute. It's operator's clinical judgment which is important. In suspected fetal bleeding disorder, predisposition to fracture, these two are relative contraindication. Outlet obstruction is absolute contraindication. So coming to ventouse, It assists delivery by creating vacuum between the cup and fetal scalp, which holds the cup firmly on the head of the fetus, and it allows traction to complete birth. It is easy to learn. It may be used with asynclitism and malrotation, and these are the types. Metal prerequisites are presentation should be cephalic, and preferably head should be well flexed. Then head should be at least at +2 station or more. Membrane should be ruptured. No CPD. Cervical dilatation must be sufficient to admit the cup. It is not used in preterm labor. An trained operator is a must. In lithotomy position, antiseptic painting, bladder empty. But a thorough clinical examination before applying doing the procedure is very, very important to assess the position of occiput and the suture line to know that head is rotated, mal-rotated, and pelvic assessment and cervical dilatation. These findings should be ascertained. Pudendal block usually suffices. Cup placement, most important. The center of cup should be at 3 centimeter in front of posterior fontanelle. Cervical rim or vaginal wall should not be included in the rim of the cup. And vacuum is created by increasing the suction by 0.2 kg per centimeter square every 2 minutes, gradually until a negative pressure 0.8 kg per centimeter is reached. Traction should be coordinated with maternal expulsive effort, and direction of pull should correspond axis of birth canal. A bigger cup size is better. It depends on the dilatation of the cervix, and size of cup should be as big which fits into, and total time should be up to 20 minutes, and cup slips off, but we have to reapply it, but generally 2 application is enough, but it is never more than 3 application. Fetal heart rate checking should be done, and maternal soft tissue trauma or extension of episiotomy, hematoma, PPH, infection are the complication, and fetal scalp laceration, cephalhematoma, intracranial injury, and neonatal jaundice, the fetal complications. If head does not descend with each pull, at first pull, the operator can sense the difficulty of descent of the head, and if it descends a little bit, and even after 2, 3 pulls, head is not descend and is not delivered, cup slips off, then it is failed vacuum extraction procedure. So the procedure should be abandoned here only. Kiwi, the most common type of ventouse, without a suction machine, the handheld pump is used, and complications are almost same as those of other vacuum. So in modern obstetrics, high and mid cavity forceps are obsolete because of high morbidity and mortality. The permissible forceps delivery is low forceps or outlet forceps, which is called lift out forceps. It results in safe outcome and uncomplicated subsequent birth if performed by trained personnel in meticulously selected cases. Complications are likely to occur when forceps is applied high in the pelvis, unrotated head, and these are the main causes of failed attempt. Alternately, doing cesarean section in second stage is also challenging, and yesterday we all heard in the oration that how difficult is cesarean section in second stage. Forceps, the function is traction, and Keelan forceps is used for rotation and traction as well. Protection, it protects from, it forms a cage, protective cage around head in, especially in preterm labor when sudden compression and decompression is protected. Uncontrolled delivery in after coming head in breech. These prerequisites all know: cervix should be fully dilated, bladder empty, membranes ruptured, head engaged at +2 to +4 station, and sagittal suture in antero-posterior position, so the head is properly rotated, pelvis adequate, uterus must be contracting and relaxing. In first, for the application in OT with arrangement of cesarean section, then blade assembles well lubricated, and dorsal lithotomy, pudendal block, and perineal infiltration is done. Then we insert our finger of right hand into vagina so that we can protect the maternal soft tissue on one side, and we should not rub the fetal scalp on the other side, and the blade is slide the left blade, which is rested on our palm hand, and gently alongside the fetal head, and similarly the right blade is applied. And if head is well rotated, the blade is applied very smoothly and it locks smoothly, and problem comes when head is not properly, a sagittal suture is not in AP diameter. If occiput is at 1 o'clock or 11 o'clock, then you can rotate it by your hand a little bit and apply forceps. And after locking, steady traction with each contraction, downward and backward till occiput comes under symphysis, and then horizontally. And right blade is removed first, fetal heart checking between contractions, episiotomy at crowning of head, and head should descend with each pull, and 2-3 pulls should be required to deliver the baby. And if at times we feel that head is at the perineum, forceps applied very nicely, and still the head is not dislodging there, लगता है कि घसक ही नहीं रहा है, then in such cases abandon the procedure. And in OP position, the direction of traction is just the opposite of OA position. Face presentation, the same type, same direction of traction. It's not after. ये घूम नहीं रहा जी. टाइम ही नहीं. नहीं. If no descent of head after 3 pull or after 20 minutes, it is considered failure, and cause is unrotated, OP position or mal rotation, big baby or mid cavity, it's high forceps. Early, every application considered as a trial of forceps. So we should always be ready for the option for cesarean section. And fetal facial nerve injury, usually self-limiting, laceration, that is also self-limiting, fracture of face and scalp, and maternal soft tissue trauma, uterine rupture, urinary retention or incontinence, fecal incontinence, hematoma, all these conditions are after observation limits. Then ventouse is an edge over forceps, that mal-rotated head, it helps in auto-rotation, it's not a space occupying device, traction force is lesser, and low rate of maternal tissue trauma, and less analgesia. And forceps is advantage for quick expedite delivery in fetal distress, and safe for premature baby, and it can be applied in anterior face presentation and after coming head in the breech delivery. These are the measures. We can reduce the need of instrumental delivery by using partogram, upright or lateral position in labor, delayed pushing in epidural anesthesia, judicious use of oxytocin in second stage, and one-to-one support to the laboring woman. So to conclude, instrumental delivery is an important emergency obstetric procedure, and there is declining trend in instrumental delivery worldwide against an alarming rise in cesarean section rate, and it is partly due to lack of appropriate training and experience as well as medico-legal issues. So it is not an obsolete procedure being practiced worldwide, but it has its own advantages, and there should be proper institutional training of forceps delivery right from postgraduate level. So an appropriately performed instrumental delivery by experienced person may help avoid unnecessary risks and reduce cesarean section rate. Doctors at the periphery, especially in our country, in our state, should be trained in these procedures where the cesarean facilities are as an alternative not available always. Thank you for it.
Respected Chairperson, seniors and dear colleagues, at the outset, I thank the organizer for giving me a topic which is very rare in itself, but now it is an emerging topic. It is pregnancy after kidney transplant. I'll be using KT for kidney transplant throughout. So the highlights, I will discuss history, which is interesting, introduction, the pre-pregnancy counseling, which is very important in this, then the effect of kidney transplant on pregnancy in terms of medical and fetal complications, and effect of pregnancy on allograft, the kidney that is transplanted, and the management, antepartum, intrapartum, labor, breastfeeding, contraception, and finally the conclusion. So the history, the first successful pregnancy in renal transplant recipient occurred in 1958 to a 23-year-old Edith Helm, who received a kidney from her identical twin sister in 1956. She delivered a full-term baby, healthy baby of 3.3 kg by cesarean section, and she herself survived till 55 years of age. The twin sister who donated the kidney, Van Foster, also gave birth 4 times successfully. Since then, there have been many successful pregnancies after kidney transplant. So organ donation is not a tragedy, but it can be a beautiful light in the midst of one. So the introduction, font is small, I think. So the era of pregnancy after kidney transplant has begun now. The prevalence of kidney transplant in the UK is 2 to 6 per 10,000 women of childbearing age, and 30 to 60 pregnancies occur annually in women with kidney transplant. The majority of women with kidney transplant will have a successful pregnancy resulting from good pre-pregnancy counseling and optimal management of pregnancy. And because it's a rare, so the current knowledge of outcomes of pregnancy after KT is limited, and we have retrospective studies from 4 voluntary registered bodies which disseminate the guidelines. These are National Transplant Pregnancy Registry, NTPR in UK, then in New Zealand, Australia, and America. And there are, of course, some studies, retrospective studies in the hospital-based also, and case reports also. So how does this kidney transplant and sexual function? So women with chronic kidney disease and end-stage renal disease, or those on hemodialysis, they have abnormal hypothalamic pituitary ovarian axis. And this leads to menstrual irregularity, loss of libido, anovulation, and impaired infertility. So in these cases, pregnancy is rare. And actually, I was lucky to have experience of these in Saudi Arabia, where there were many cases of end-stage renal disease. And they always come with all these problems, menstrual irregularity and impaired fertility. However, KT, kidney transplant, restores the HPO axis rapidly and offers the best hope to become pregnant. Now, what are the challenges in pregnancy after kidney transplant? First of all, side effects of immunosuppressive agents as well as their teratogenicity. Font bada nahi ho sakta hai. Acha. So side effects, then risk of allograft function deterioration due to pregnancy, risk of adverse maternal and fetal complications due to underlying maternal pathology, and the pregnancy is labeled as high risk as we are dealing with 3 entities: the mother, the fetus, and the allograft. So What are the good predictors? This is very important, of successful pregnancy after kidney transplant. So once the patient has been transplanted, you have to see that she has normal or good kidney with GFR more than 60 ml per hour, no sign of end organ damage. There should be an interval of 1 to 2 years after transplants. Americans say 6 months only, but usually UK and other bodies say 1 to 2 years after transplant you should avoid pregnancy and then only contemplate. Then there should be scant or no proteinuria, defined as urine protein less than 500 milligram in 24 hours, and serum creatinine should be less than 1.4 milligram. So women should be on, once she has kidney transplant, she should be on low dose immunosuppressant agents like calcineurin inhibitors, cyclosporin or tacrolimus, azathioprine and low dose prednisolone. These are the drugs recommended as immunosuppressants in pregnancy. She should have normal or well-controlled BP less than 140/90, preferably on safe monotherapy. No recent history of acute rejection of kidney should be there. So this is the ideal kidney which should go for pregnancy. However, kidney which is in non-ideal condition, that does not fulfill all these conditions, is an example of bioethical conflicts. Autonomy, if she wants, let her go, but do no, as a clinician, do no harm than good. Pre-pregnancy counseling, as is very, very important in these cases. As pregnancy after kidney transplant is a high risk, hence pre-pregnancy counseling must be done. So while you are doing safe and effective contraception is recommended until pre-pregnancy counseling has taken place. Conception is not recommended within first year of transplant as the dose of immunosuppressant is very high and graft stability is difficult to assess. Risk of graft rejection is estimated to be as high as 10 to 15% in the first year of the transplant. And teratogenic immunosuppressants like mycophenolate, mofetil, sirolimus should be stopped immediately, and a 3-month washout period should be given before contemplating pregnancy. At the same time, they should be switched over to the low dose, safer immunosuppressants. ACE inhibitors and ARBs used for hypertension should be stopped and switched over to safer methyl dopa, labetalol and hydralazine. Statins and warfarin should be stopped, folic acid should be started, and with this counseling, the pregnancy associated risk is minimized in advance of conception, and moreover, the patient also becomes mentally prepared for the possible complications. So it's very important, this pre-pregnancy counseling. Now, what is the effect of kidney transplant on pregnancy? The effect is on maternal and fetal. So hypertension in pregnancy after kidney transplant is very common, 52 to 69%. In general population, it is 5 to 10%. Incidence of preeclampsia ranges between 24 to 38%, that is 6-fold higher risk compared to incidence of 4 to 5 in general population. Hyperuricemia, which becomes less reliable marker for prognosticating preeclampsia as the patient is usually on calcineurin inhibitors, which increases the serum uric acid level. So you cannot judge the gravity of preeclampsia by uric acid level. And risk of recurrent UTI, hydronephrosis and asymptomatic bacteriuria and pyelonephritis are increased frequently. Risk of other infections like CMV, herpes simplex and hepatitis B and C are more than in normal pregnancy. And due to hypertension, preeclampsia and other maternal morbidity, there is many-fold more fetal risk compared to normal pregnancy. Like preterm birth is 40 to 60%, 13-fold increase, low birth weight 12-fold increase, hence sick babies and NICU admission is increased. Miscarriage rate ranges from 11 to 26% compared to 8 to 9 in general population, just double. And cesarean delivery is more common due to obstetrical reasons and reported as high as 43 to 64%. During cesarean, abdomen should be opened longitudinally to avoid trauma to the allograft, which is usually placed extraperitoneal in the right iliac fossa. GDM is more common in patients who are on prednisolone. And data suggests that multiple pregnancies and IVF conception have higher risk of complications, and they should be intensely monitored. No evidence that children from kidney transplant mothers have high risk of congenital malformation, except that mother already has genetic disease like autosomal dominant polycystic kidney disease, etc. Now, what happens to effects of pregnancy on allograft? Rate of allograft is not increased, rejection is not increased during pregnancy or 3 months postpartum, and varies between 1 and 14.5%, which is comparable to non-pregnant transplant recipients. So there is no more allograft rejection in pregnancy as such. However, if risk factors still persist like hypertension, proteinuria, or creatinine more than 1.4 gram, then acute rejection of allograft occurs. High dose steroids have been successful in treating allograft rejection and remains the first line treatment. Antenatal management, multidisciplinary team, then all the first trimester investigations, but emphasis on renal function and proteinuria. Data suggests that renal functions and level of immunosuppressant drugs should be tested every month. UTI is very common, 40%, so it should be tested at every visit, and urine culture at 4 weeks intervals. Asymptomatic bacteria should be treated with antibiotics for 4 weeks, and then prophylaxis should be continued throughout pregnancy. The antibiotic to treat UTI include nitrofurantoin and cephalexin. Blood pressure should be maintained below 140 to 90, and women on calcineurin inhibitors and steroids should be strictly screened for GDM. Fetal growth scan at 26 to 28 weeks and 32 to 34 weeks. There is increased requirement of erythropoietin, and so it should be given. Magnesium sulfate can be used for maternal preeclampsia and fetal neuroprotection, and low dose heparin is recommended throughout pregnancy. Vaginal birth, intrapartum management. Vaginal birth is the recommended mode of delivery. Continuous fetal monitoring is recommended. Induction agents, prostaglandins and oxytocins are safe to use. CS rate is 5-fold increase due to the obstetric complications. The transplanted kidney is extraperitoneal and does not obstruct delivery. However, the risk of trauma to the allograft during cesarean is 1 to 2%. Contraception, safe and effective contraception includes progesterone-only pill, desogestrel, Mirena, and progesterone implant. Breastfeeding, transplant recipients can take safe, like if she's on safe drugs, she can continue breastfeeding, as transfer of these drugs to breast milk is far less than placental transfer. So the summary is kidney transplant improves fertility in CKD and ESRD patient and gives hope to women to become pregnant. Pregnancy in these women become challenging due to maternal and fetal complications, side effects of immunosuppressants, and risk of allograft rejection. Pre-pregnancy counseling is highly recommended to minimize the complications, and the patient with ideal kidney function should only contemplate pregnancy. The recommended immunosuppressants are cyclosporin 2 minutes. Optimal time to conceive remains an area of contention, but usually 1 to 2 years, and breastfeeding is not contraindicated. Vaginal delivery is recommended, but C-section is increased 5-fold times. Take-home message, reproductive function in women with end-stage renal disease generally improves after kidney transplant. However, pregnancy remains challenging. The strength of a shoulder, the hands of a donor. Be a hero, be an organ donor. Life is a gift, pass it on. Thank you.
Thank you, Dr. Zareen. That was a very comprehensive presentation on a new entity that we see now. Lots of us are, managing patients with kidney transplant, and we should not shy away. Two things are very important, which she did highlight. First, that pre-pregnancy counseling is actually very, very important. The second thing is we should always, this is a multidisciplinary management of the patient, so we should be in constant touch with the nephrologist. And also, cesarean section, it's not a must, But if at all we do resort to it, then we should be very careful, especially she mentioned the longitudinal incision. I'm glad you did that. And they can breastfeed and also contraception. Thank you, Dr. Zubin.
Thank you, Zareen. That was very nice. In, say, a patient, we had a patient of 33 weeks pregnancy with PROM. The LICA had drained completely, the baby was live, and she was a patient of renal transplant. What were the, what do you think would be the complications in that? And how would you go about it?
Yeah, she's asking question.
She's 32 weeks, you said, with
33
PROM
weeks,
and renal transplant. So it's again a challenging thing because she's already PROM, so signs of infections are there, can be there. So she should be put on antibiotics, and we can continue her pregnancy till maturity and then deliver her.
And prednisolone, if the patient is on that, how, do you recommend continuing it throughout pregnancy?
Which thing?
If she's on prednisolone,
Low dose prednisolone we can give.
you can carry on throughout
Yeah,
pregnancy?
low dose is given.
Thank you so much.
Okay.
All right, can I request both the chairperson and one of our speaker to please come here? Can we have a round of applause to our chairperson and all the great speakers giving so much of fruitful knowledge to all of us at the Labourcon 2023. Well, with this, we're gonna move forward for these next set of talk. There are 3 speakers who will be coming in, and we got Dr. Seema Singh and Dr. Kamini Chaudhary to please come forward as chairperson. Dr. Seema Singh. You're welcome. Thank you, ma'am. Dr. Amita? Dr. She didn't get her certificate. Dr. Seema is here, and Dr. Kamini. Now I request the chairperson to quickly invite the first speaker, please. Thank you.
Hello. Good morning, everybody. And thank you, organizing committee, to give me opportunity to attend such a session. Now, I request Dr. Nilakshi Kumar, first speaker. Dr.
Very good morning to you all.
The topic is epilepsy in labor.
So, respected chairperson, thank you, the organizer, thank you, Dr. Meena, for inviting. This is my second visit to Patna. I came way back when AICOG was organized, and I was a PG student at that time. I had a very memorable stay here in Patna, but our return journey, I will always remember. That time, there was no flight. We used to travel by train. So, train got cancelled. What to do? From Patna to Guwahati, it took us 36 hours. We went by bus. That was a very memorable journey we'll never forget in our life. So let us see what epilepsy in labor we should know, because we get very few cases. All of us will admit that how many cases we have seen with epilepsy? Very few. I bring greetings from Ma Kamakha. But we know that epilepsy in our society is still considered as a taboo, and most of them, they don't disclose that they are suffering from epilepsy. So there the problem lies. So it's a very common neurological disorder. It is associated with twofold increase in the incidence of congenital anomalies, because the drug used as an anti-epileptic drugs is mostly causes folic acid deficiency and lot of congenital anomalies. So there are different studies have shown that epilepsy and pregnancy is extremely risky. And some studies have shown most women who have epilepsy during pregnancy can deliver a healthy babies like a normal pregnancy. There are a lot of evidences shows that Seizures in pregnancy are related to miscarriage, stillbirth, preterm delivery, antepartum and postpartum bleeding, C-section, increased incidence of C-section, development delay and congenital malformation. But this is, some studies support this and others they deny. What is the incidence? 1 in 6 women with epilepsy in India, accounting for 2.7 million patients in country. Out of that, 52% of them are in reproductive age group. Statistically, 0.3 to 0.5% women giving birth suffering from epilepsy. These are the, just to complete my talk, this are the different types of epilepsy we see. When we see that tonic and focal seizures are usually associated with sudden unexplained death. The seizures in pregnancy may be the first time, I mean, it is already, we know about the history that she is having seizures, and second is the new onset seizures, and the most common, we are quite familiar with the eclamptic fits. So risk or maternal death rates are 10-fold higher for women in pregnancy than in general population. Sudden unexpected death in epilepsy rate in younger epilepsy patient is close to 10 times that of the general population. And in the general population, it is about 2 to 3%. The effect of pregnancy on epilepsy, this is because there is discontinuation of medication, poor cooperation with the patient, non-compliance with medical instruction, and sometimes there is status epilepticus and SUDEP syndrome. This is all because of the physiological and metabolic and hormonal changes that occur during pregnancy, which alter the pharmacokinetics of the drugs, and which leads to lower bioavailability of the anti-epileptic drugs, and thus causes, it causes seizures. So we have to measure the serum concentration of the anti-epileptic drug, and therewith we may have to increase the dose of anti-epileptic drug after consulting the neurologist. So when first fit we see, these are the group of investigation we should do. So maternal epilepsy, so what is the effect on pregnancy? So effect of pregnancy is uncertain. Or the anticonvulsant interfere with the metabolism of folic acid, as I have already said. There may be anti-D and other congenital malformation. No increase in the risk of miscarriage and obstetric complication, unless a seizure results in abdominal trauma. Relatively resistant to short episodes of hypoxia, and there is no evidence of adverse effect of single seizure in the fetus. So during pregnancy, the serum concentration of AED decreases, as I have already told. These are the list, which are the most affected medicines. So key element in the care of epilepsy in the childbearing age group is the pre-pregnancy counseling, proper control of the seizure. But unfortunately, 40% are still unplanned. So lowest effective dose of AED should be prescribed. Discontinuation of, sometimes what happens, suppose the lady is free of fits for last 3 years. In those cases, we may discontinue the medicine. What is observed that the patient, suppose the lady is not having fits for last 9 months to 12 months, then there is a tendency that she will be seizure free throughout the pregnancy and labor. So the European registry have shown that the pregnant women with idiopathic generalized epilepsy are more likely to be free of seizures than the focal epilepsy. These are the congenital anomalies. I will quickly go through it. These are the types of commonly seen with the medicine. So pharmacokinetics, why there is low level of concentration of anti-epileptic drugs? Because of the volume expansion, alteration in protein binding, increased clearance rate, nausea and vomiting, decreased or non-compliance of the medicine, and sleep deprivation. And then another, when providing care for pregnant women with epilepsy, physicians should be aware of the possible minor risk increases in complications during pregnancy, particularly women with anti-epileptic drugs. So that is why thorough ultrasound, including the first trimester for anomaly. Then these are the patients who have a high incidence of small foreheads. The growth scan is very much necessary, and special attention should be given for the biometry in the third trimester. So there are some AEDs, anti-epileptic medicines, which induce hepatic enzyme, and those are the patients where we should start vitamin K, 20 milligram per day during the last 2 weeks before delivery, and then 1 milligram vitamin K to be given to the newborn. And suppose the patient goes for, there is a tendency for preterm labor, routinely we use steroid. There is no alteration of the drugs, steroids, where they are the patients who are on anti-epileptic drugs. So, management of newly diagnosed case, I will not go in details. I think there won't be so much of time. So delivery, the main point. So delivery in women with epilepsy, administration of anti-epileptic drugs should be continued during labor as per the neurologist's recommendation. Parenteral administration should be an alternative one. And induction of labor, as because she is epileptic, there is no such indication for induction of labor. Suppose there is some obstetric indication, then of course we'll go for induction of labor. So labor can increase the stress in women, affecting overall health. Other contributing factors we may trigger is the missed medication, sleep deprivation, and overbreathing due to panic attack. That in those situations, she may develop epileptic fits. It is now not widely used, the patidine, but it should not be used. It is a contraindicated because it increases the incidence of seizures. Then there is no known contraindication for the use of labor inducer women with epilepsy taking anti-epileptic drug. We can use the labor inducer. It should always be delivered in a tertiary care center. Counseling risk of having seizure during labor and after delivery is low, approximately 1 to 2%. We must counsel the lady. Adequate pain management, if needed, go for epidural analgesia, because we know the pain and sleep deprivation may increase the chance of epileptic fits. So hypoxia as well as fetal hypoxia and acidosis secondary to increased tension of the uterus should be looked after. Seizure may cause placental detachment and sometimes fetal hypoxia. We must be very aware, and the team must be very vigilant. Suppose there is seizure during pregnancy. What you do? We go for, these are the drugs, lorazepam, diazepam, phenytoin. And in uncontrolled cases, the phenytoin is the best one. And if uncontrolled, we can use additional drugs to control the seizure. Do we have to go for elective C-section in epilepsy? Epilepsy and pregnancy do not constitute an indication for surgical delivery. If there is obstetrics indication, yes, we can do. Otherwise, as such, there is no such indication. Only indication in epilepsy is a refractory to treatment during 3rd trimester. If there is status epilepticus, repeated psychomotor or absent seizure, which limits maternal awareness and maternal ability to cooperate, then we have to go for C-section. Status epilepticus, what we are very much scared of. Maternal effect, it causes metabolic acidosis, acute renal failure, irreversible brain damage. Fetal effect, fetal hypoxia and asphyxia and IUD, preterm labor, PPROM and abruptio placentae. So management, it is an obstetrics and medical emergency. Immediately secure maternal airway, O2 inhalation, left lateral position. IV fluid to avoid hypotension and investigate for RFT, renal function test, LFT, electrolytes, AD level in blood, and CSF if indicated, not in all cases. Control of seizure, I have already shown this slide. The same we have to do. Suppose it is uncontrolled one, then it is refractory to treatment. In that case, intubation should be done in those cases. Postpartum, we must be very vigilant because now, suppose we are increasing the dose of AED in the latter part, 3rd trimester, and then because of the changes, what takes place in postpartum period, there may be a level of AED is quite higher in the blood, and that might causes some other complications, and not only to the mother, also to the baby, newborn. Then the psychological changes that occurs during pregnancy, such as increased renal and hepatic clearance and hemodilution, resulting in high dose of AET toxicity to the newborn. The drug concentration should be determined within 10 days of postpartum and the dose reduced according to avoid postpartum toxicity. The newborns delivered by women taking drugs should be monitored for adverse effects like lethargy, feeding difficulty, excessive sedation or withdrawal syndrome. Women with epilepsy displays an increased incidence of depression, postpartum depression. So the take-home message, all ladies who are planning for pregnancy with epilepsy should have a planned pregnancy. AED is known to cause birth defects. Seizure control before pregnancy is an important control to seizure during pregnancy. Dose of AED may change in antenatal period. Use of AED during labor should be continued with consultation with neurologist. Women with epilepsy should be delivered in the tertiary care center, special care for pain management, adequate sleep, and please observe for postpartum psychosis. Thank you for your patient hearing.
Thank you, doctor. It was wonderful talk. As you well said, it is still considered as a taboo in the society. We should motivate them, counsel them for pre-conception, during conception, and also in the puerperal period to be in our contact so that they can be always properly treated. And you well explained, it is very useful for us. Thank you again for being here and give a wonderful talk.
Thank you everyone.
Thank you. Next speaker is Dr. Amita Sinha, and her topic is SLE in pregnancy.
Good morning, respected chairpersons and dear friends. At the outset, I would like to thank the organizing chairperson and organizing secretaries for giving me this opportunity. My topic is SLE in pregnancy. Before I describe this case and discuss about all these important points, I would like to share a story with you. Very soon, just 2-3 months back, one patient came to me at 29 to 30 weeks of gestation with history of severe dyspnea. And she has great problem of dyspnea. Then I general examination, did obstetric examination and referred this case to physician. And after the examination, the patient came to me with a diagnosis of massive pericardial effusion. Finally, patient was transferred to ICU cardiac unit, and pericardial tapping was done, steroid was started, and within a week, patient improved, and she delivered, though she delivered prematurely, and diagnosis was SLE. And it was my first case, and patient was unknown to this disease, and it was diagnosed only in pregnancy. So with this background, let me start my presentation. We all know that SLE is a rare multi-system chronic autoimmune disease in which the tissues are damaged by autoantibodies and immune complex. Disease affects mainly women in ratio of 10:1 if we think of women versus men, and prevalence of SLE in women of childbearing age is around 1 in 500. What are the common clinical features? Mainly SLE, either in pregnancy or non-pregnancy state, it presents with arthritis. Second one is skin presentation. It also presents in the form of pleuritis, pericarditis, glomerulonephritis. Neurological symptoms are also very common, hematological disease. So she may present with different type of manifestations. This is the diagnostic criteria given by the Society of Rheumatology. Patient may present with malar, rash, discoid, rash, photosensitivity. All these things are, she may present with oral ulcer, non-erosive arthritis, as I mentioned earlier. But why it is important to differentiate these findings from pregnancy? Because there is some overlap. Pregnancy is also some type of rash like chloasma. We always see that we should know how to differentiate between chloasma versus malar rash, Proteinuria is also common in pregnancy, but it is secondary to preeclampsia versus proteinuria due to lupus nephritis. Preeclampsia versus kidney disease due to an exacerbation of lupus. Thrombocytopenia in pregnancy is also very common due to preeclampsia, but we have to differentiate it from ITP or TTP. Similarly, pedal edema, it is also seen in pregnancy very commonly, but SLE is also a type of manifestation. So these are the common pregnancy-related complications in SLE: hypertension, preeclampsia, HELLP syndrome, antepartum hemorrhage, prematurity, IUGR, and gestational diabetes too. Why it happens? Because we use most of the time corticosteroid in this condition. So we have two concerns in our mind. What will happen to pregnancy due to SLE, and does pregnancy causes some problem in SLE? So both the factors are very important to know. So let's see what happens in SLE, what is the effect of SLE on pregnancy. So mostly I told you that there is a spontaneous miscarriage, fetal death, eclampsia, and these are related to different type of antibodies present in the body. Or is the condition is active at the time of conception, or first presentation of SLE during pregnancy. These are some factors which affect its effect on pregnancy. Sometimes patient comes with organ damage at the time of pregnancy. It may have difficulty because pregnancy adds to the burden on malfunctioning of the organs. Pregnancy in women with lupus nephritis is associated with increased risk of fetal loss. So patient may come to us with complication also, or with organ damage also. Not only SLE is diagnosed first time in the pregnancy and we see its flare up or complication. Patient may land up with complications already having before pregnancy. But what data says? During pregnancy, lupus improves in a third of women. It remains unchanged in a third and worsens in the remaining third. Sometimes if we are lucky, we don't see any flare, don't see any complications, and outcome is very good. Because sometimes it improves during pregnancy. But many studies have shown that clinical condition can worsen or flare without warning. So we should be alert if it is diagnosed, or if we have suspicion of any sign and symptom, we should consider it as high-risk pregnancy and give appropriate care. But in some condition, we have also good pregnancy outcome, like lupus activity is quiescent for at least 6 months before the conception. There is no anti-RO, anti-LA bodies, no cardiac lung involvements, so we can have good pregnancy outcome as well. Let's see what is the effect of pregnancy on SLE. In some studies, it has shown that SLE may improve or SLE may flare up. In general, pregnancy does not cause flare of SLE. Flares that do develop often occur during the first or second trimester or during the first few months after delivery. And the frequency of exacerbation or persistently active disease varies with disease activity at conception. Or at the time of conception, what is the condition of disease? It is main factor that causes exacerbation or normal quiescent stage. It rates ranges from 7 to 33% in women who have been in remission for at least 6 months at the time of conception, to 61 to 67% in women who have active disease at the time of conception. Kidney disease flare is the most common exacerbation seen, that is lupus nephritis. Increased SLE disease activity is expected during pregnancy because of increased level of estrogen, prolactin, and T helper 2 cell cytokines. And the incidence of exacerbation during pregnancy and postpartum period, now it has been progressively diminishing due to good treatment and early diagnosis. There may be other associated condition, UTI, gestational diabetes, premature rupture of membrane, preeclampsia. So how should we evaluate this condition? So what if the case is diagnosed, we should do at the first visit physical examination, kidney function test, complete blood count, and we should also rule out the test for anti-RO SSA and anti-LLA SSB antibodies. These two are very important. Lupus anticoagulant and anticardiolipin antibodies, anti-double standard DNA test, and complement test. These 5 tests are very important in initial visit. So, and other than, if the patient comes with other organ system dysfunction, we should go for detail, like if she has cardiac system, respiratory system, renal system, hematology and immunological system, we should refer the patient to appropriate place for numerous investigation and to rule out the other condition and early management. Okay, because we can't manage this SLE case in pregnancy alone. It needs multidisciplinary treatment. This is PROMISE study. It has shown that there are 2 circulating hormones that gives negative predictive value in first trimester. So coming to antenatal care, as I told that in first trimester we should go for some investigation, and because our objective should be to treat the patient both by obstetrician and rheumatologist, same as normal non-SLE antenatal care we should give. We should search for SLE related pregnancy complications are there or not, regular monitoring of fetal conditions, and patients suffering from active disease should be kept under special observation. And follow up at subsequent visit, we should again do all these tests that I mentioned earlier, review every 4 weeks for from 16 to 28 weeks, like just normal antenatal care if patient has no problem. Each visit should be documented the presence or absence of flare or preeclampsia symptom, blood pressure, dipstick urine analysis, symphyseal fundal height to rule out the IUGR, and fetal heart rate. In every checkup we should do this. Low dose aspirin and low molecular weight heparin should be started in consultation with physician. Women with previous hypertension, because we are here confused with either it is simple preeclampsia associated with the pregnancy or it is manifestation of SLE. So we must take care opinion of physician. Proteinuria or dipstick analysis would necessitate confirmation and quantification by either PCR or 24 hours collection. Women on steroids or those with previous gestational diabetes mellitus should have a screening for gestational diabetes, ideally at 16 weeks, and if negative, again at 26 to 28 weeks. Lupus, pregnancy, nephritis, and eclampsia. These are very overlapping conditions, so I'm not going into detail. So we must evaluate fetal growth and vitality, level 2 scan, level 1 scan, whatever we do. If fetal echo is suggested in this condition, because fetal echo at 22 weeks of gestation for women with anti-SSA, anti-SSB antibodies to exclude congenital heart block, because lupus, congenital lupus is very common. Neonatal lupus is one of the side effects in condition of having these antibodies. Bilateral uterine notch between 23 to 25 weeks is a risk factor for development of early onset PET. Like we should manage biophysical profile, Doppler velocimetry, fetal umbilical artery, Doppler beginning at 26 to 28 weeks, continuing weekly until birth. These are the common differentiating points that we see in preeclampsia and lupus nephritis. Usually lupus nephritis having so many differences between clinical measures from preeclampsia, and kidney biopsy is the final diagnostic method that we don't do. Just on the basis of clinical finding, we diagnose the case whether it is lupus nephritis or preeclampsia. Fetal complications, again very common: prematurity, IUGR, reduced Likert, fetal distress, and risk factors for premature delivery are antiphospholipid antibodies, active SLE at conception, SLE flare, renal disease, and high BP. The main features of fetal complications is congenital heart block, transient cutaneous lupus lesion, cytopenias, hepatic and other systemic manifestations. Especially this lupus syndrome, neonatal lupus syndrome, is an unusual condition due to the passage of maternal antibodies, especially anti-RO-SSA and anti-LA-SSB to unborn fetus. So fetal echo should be done to diagnose fetal heart block. If there is finding of hydrops in a fetus with congenital heart block, it is an extremely poor prognostic sign with a mortality rate of 83 to 100%. So neonatal lupus should be diagnosed early. This is one of the severe complications where we can't save the baby. So what is general advice? We advise patient to avoid sun exposure. It is very important to prevent flares. Mothers should take low salt diet, adequate amount of vitamins, minerals. These are the drugs which are safer during pregnancy: folic acid, hydroxychloroquine, and low dose aspirin. Though there is controversies of using a steroid because it causes flare up, but it is the treatment. So with the consultation of again physician, we can use low dose corticosteroid, and it is the treatment of lupus flares. So these are some of the drug side effects, but azathioprine and cyclosporine, these drugs are safe during pregnancy. So to prevent all these maternal and parental mortality, pre-pregnancy counseling is very important, and we should check for antiphospholipid antibodies. Patients should avoid pregnancy with lupus is active, especially in the presence of active lupus nephritis, which can be exacerbated during pregnancy and difficult to control. Women with SLE who are considering conception should undergo risk assessment for adverse pregnancy outcome. If we see the prognosis, more than 50% of all pregnancies in women LIFAs have normal outcome. 25% of women deliver healthy babies prematurely. Fetal loss is occurring in fewer than 20% of cases. Despite improved survival rate, mortality rates in patients with SLE remains 3 to 5 times greater than in general population. So thank you so much.
You covered all the aspects, pre-conception counseling and intrapartum, antepartum, all the covers. I think pre-conception counseling is very important.
Very important, yes.
And if patient diagnosed, then you should plan for during the quiescent period.
Quiescent period. So that she can conceive after 6 months of quiescent period. Then flare-up is very minimal.
By chance, if baby delivered with congenital heart block, then we must see whether the patient is suffering from SLE or not.
Yes, yes.
Sometimes we miss the during
Then we should all the skin, all the antibodies again for her further pregnancy.
Further pregnancy.
Yes.
Thank you.
And now I request Professor Kalpana Singh for her talk on HELP syndrome. Professor Dr. Kalpana Singh, please.
Good morning, chairpersons. First of all, I would like to express my thanks to organizers for giving me this opportunity to speak on HELP syndrome. As we all know, that HELP syndrome is a serious complication in pregnancy, which is characterized by hemolysis, elevated liver enzymes, low platelet count, occurring in 0.5 to 0.9% of all pregnancies, and in 10 to 20% of cases with severe preeclampsia. So in today's presentation, I'll be discussing the highlights in occurrence, how to diagnose the complications, how to diagnose the condition, surveillance, role of corticosteroid treatment, mode of delivery, and risk of recurrence. The syndrome of hemolysis with microangiopathic blood smear, elevated liver enzymes, and low platelet in pregnant and postpartum women is more commonly known as the HELP syndrome. It represents a complication or progression of severe preeclampsia. However, the preceding hypertension or proteinuria may be absent in at least 15 to 20% of patients with HELP syndrome. So we must always be alert. It's not necessary that in all patients they will have preceding symptoms. So far the epidemiology is concerned, prevalence is 0.5 to 0.9%, and in 70% of cases it occurs in third trimester, but it can also happen in postpartum period for the first time. And mortality rate, it has a various range from 0% to as high as 24%. Coming to the risk factor, age is a risk factor, extremes of age is risk factor, multiparity, and there are certain set of genes, genetic predisposition can be there. We all know that this happens because of the inadequate trophoblastic invasion leading to failure of remodeling, ischemia in placenta, and multi-organ microvascular injury leading to liver and vascular dysfunction. So I will not be going in detail of this, but we all know that what happens ultimately, that there is microorgan microvascular injury, there can be hepatic necrosis, elevated liver enzymes are there, then there is consumption of platelets, thrombocytopenia happens, and because of the breakdown of RBC, hemolysis happens. So far the clinical symptoms are concerned. There is a very typical symptom, that is right upper quadrant pain. Whenever any patient having preeclampsia complains of right upper quadrant pain, one should have a suspicion of HELP syndrome. It can be accompanied by, most of the time, by nausea and vomiting. Other uncommon symptoms are fatigue, headache is a common symptom, pedal edema. Sometimes patient may have visual disturbances. On examination, blood pressure may be raised most of the time, more than 140 to 90 mmHg. There can be pedal edema, right upper quadrant or epigastric tenderness, icterus, and visual disturbances can be documented. Coming to the investigations, CBC should always be done. Peripheral blood smear is again a useful test. Liver function test, and here we can see AST and ALT, bilirubin should always be the part of LFT. Creatinine, liver function test. If impaired, we can go for heptaglobulin, which is a very specific test for HELP syndrome. Then lactate dehydrogenase and coagulation studies, they help in deciding the management. Now coming to the diagnostic criteria, one of the most important is documentation of hemolysis. Hemolysis should be there. And how to diagnose hemolysis? We can see abnormal peripheral blood smears, especially steatocytes or helmet cells, then elevated liver, elevated bilirubin, which is usually more than 1.2 grams. There is low serum heptaglobulin, this is very specific test, and increase LDH. Elevated liver enzyme has to be there, especially AST and ALT should be twice the upper limit of normal value, and low platelet count, that is less than 1 lakh per ml. So there are various criterias. So in Mississippi classification, all the 3 features should be there, and then again depending on the findings, there can be class 1, class 2 and class 3. While in Tennessee classification, it can be complete HELP syndrome or incomplete or partial. Incomplete, all the 3 features, hemolysis, evidence of liver enzyme damage is there, but in cases of partial, either of or 2 may be present. What histopathological finding we can see? So in liver, we find fatty infiltration, intravascular fibrin deposits, neutrophilic infiltrates, sinusoidal obstructions, intrahepatic vascular congestion, hepatic necrosis, and periportal hemorrhage can be there. Now coming to the management, how we are going to manage once we have diagnosed that she is a patient of HELP syndrome. So management has to be done only in a tertiary care center. We have to stabilize the patient. Termination of pregnancy has to be planned. Early recognition of complications has to be there. Then appropriate child care and postpartum management has to be there. So, and when we come to the management of pregnancy, antihypertensive therapy or antiepileptic therapy has to be given, correction of coagulation abnormality, and termination of pregnancy. So immediate delivery of pregnancy is indicated if pregnancy is more than 34 weeks or at any gestational age, if there is evidence of pulmonary edema, renal failure, placental abruption, severe liver dysfunction or bleeding, non-reassuring fetal status, or uncontrollable hypertension. Steroid administration is done for fetal lung maturity only if maternal condition is stable and at gestational age of less than 34 weeks. Beyond that, we don't have to give steroids. Mode of delivery is usually vaginal unless until there is an obstetric indication, and if vaginal delivery is not seen within 12 hours, it is better to perform cesarean. Platelet transfusion is indicated if the counts are less than 50,000 and patient shows some bleeding manifestation. Neuroaxial anesthesia is avoided if platelet count is less than 70,000, and plasmapheresis may be done in non-responsive patients. So to give or to not give steroid, there is a controversy. So Cochrane database systematic review, which included 11 randomized trial, concluded observed that there was no difference in the risk of maternal death, severe maternal morbidity, or perinatal or infant death. The only effect of treatment on individual outcome was improved platelet count. The authors concluded that the evidence is insufficient to support the use of steroids. So universal use of steroid is not recommended. So there are many dreaded complications we know in terms of hepatic failure, renal failure, DIC, sometimes hepatic necrosis or subcapsular hemorrhage. These all can happen. So here we can see that subcapsular hematoma can be seen in a patient of HELP syndrome. Now, maternal morbidity associated with HELP syndrome. Abruptio placentae. We all know that abruptio placentae is a dreaded complication, and it can be seen in 10 to 15% of patients with HELP syndrome. Then DIC. Again, if any patient goes in DIC, that is a dreaded complication, and it can happen in 10 to 15% of the women. Pulmonary edema in 6 to 8% of women. Acute renal failure in 5 to 8%. Adult respiratory distress syndrome in 1 to 2, and death can happen in 1%. This is as per the data in published in Journal of South Asian Federation, but it can be up to 24%. There are various differential diagnoses, because many times the symptoms and diagnosis is not clear, so we must always keep the possibilities of differential diagnosis and should be ruled out, like acute fatty liver of pregnancy, viral hepatitis, hyperemesis gravidarum, or cholecystitis. These all can have elevated liver enzymes. Then diabetic ketoacidosis, hemolytic uric syndrome may have features of hemolysis, and thrombocytopenia, thrombocytopenic thrombocytopenia purpura. Here platelet counts would be low. So at times we can, the symptoms can be confusing, quite confusing. So there are some important differential diagnoses in AFPL and thrombocytopenic purpura. Here what happens that there is prolonged PT and APTT, then there is increased serum creatinine, and there is profound hypoglycemia can be there. While TTP presents early in pregnancy, then there can be high LDH and modestly raised AST can be there. Now coming to the recurrence. The risk of recurrence in HELP syndrome is 19 to 27%. So if any patient who gives history of HELP syndrome or preeclampsia in a prior pregnancy, one should be vigilant that in this patient, ongoing pregnancy or in subsequent pregnancy, there is risk. The risk of recurrence for any type of preeclampsia is 42 to 43%. So eclampsia, preeclampsia, the recurrence rate is higher. So thank you all for your patient hearing.
Thank you, Dr. Kalpana, for this very knowledgeable talk on you on the HELP syndrome, which is very dreadful condition during pregnancy and with many dreadful complications, which has been explained by you well, and that will be useful for us. Thank you.
Thank you.
Hello. And one important thing she told us, when patient come with pregnancy with pain abdomen, and actually, so do not neglect the patient. It is very important message.
All right, can I request speakers and chairperson to quickly come for a group picture, and we'll move forward. Please come for a group picture, ma'am, quickly. I have 40 seconds left of this session, so I'm allowing for the picture. नहीं वो timer यहाँ का है, system का है. Just ignore that. Sorry, ma'am, I won't be able to. You can ask someone else to do it. All right. For this session 3, it's going to be an expert talk. We got 4 speakers who will be talking about it. Backdrop लगा दो. वो नहीं हो पाएगा, ma'am. Okay, last 10 seconds so you all can smile, looking at the camera. जल्दी से दे दीजिए. Okay, last 5 seconds. Chalo, 3, 2, 1, last picture. 3, 2, 1, thank you so much. We'll move forward. I'll be inviting the chairperson, Dr. Ranu Singh, followed by Dr. Kanchan Prasad and Dr. Ruma Goswami, please. can I request the chairperson to please come forward, and it's time to invite the first speaker. Thank you.
Very good morning. Our first speaker is Dr. Prachi Singh. She will speak on peripartum cardiomyopathy.
Okay. Very good morning, respected chairpersons. Before I start, I would like to thank the organizing committee for inviting me to speak in this very successful and prestigious conference of Labourcon 2023. My topic is peripartum. Okay. I will be talking on peripartum cardiomyopathy, and it is a very important topic because we know that cardiac disorders or cardiac conditions are increasing nowadays because of the lifestyle that we are having, because of increased obesity, increased diabetes, and increased hypertension in reproductive age women. So this is the reason why incidence of peripartum cardiomyopathy is increasing, and we have to at least know how it presents. It is not a very rare disorder. It is a very long definition which has been given by the European Societies of Cardiology, but it is very important. Every line is very important. Peripartum cardiomyopathy is idiopathic. We don't know what is the cause of cardiomyopathy. It presents with heart failure, secondary to left ventricular systolic dysfunction. So there is heart failure, and it is due to systolic dysfunction. And when does it present? It presents towards the end of pregnancy or up to 6 months following delivery. So this is the time limit in which it presents. And it is a diagnosis of exclusion because no other cause of heart failure is found. The left ventricle may not be dilated, but ejection fraction is always reduced to below 45%. So this is a very important criteria for diagnosis, that ejection fraction has to be reduced less than 45%. The incidence, as I said, has been found to be increasing because of advanced maternal age, preeclampsia, multiple gestation, especially with the reproductive treatment that is available nowadays, increasing risk of cardiovascular risk factors in reproductive age women, as I have mentioned, hypertension, diabetes, and obesity. The incidence is highest seen in Nigeria, where it is 1 in 100. In Japan, it is very rare. In India, I could find from various authors that the incidence is around 1 in 1,340. And I'm sure that the incidence is more than this. It is that maybe peripartum cardiomyopathy is not so easily diagnosed. We always have to think about it. What are the risk factors if the mother's age is more than 30 years? If she has coincidental preeclampsia, eclampsia, if she has a chronic hypertension, anemia, if there is history of substance abuse, asthma, autoimmune disorders, and in USA, black women are seen to be more predisposed. Coming to pathogenesis, this is very important because it will help us in management also. It has been hypothesized that two-hit model is necessary. First of all, there has to be an underlying genetic predisposition. Not every patient will have peripartum cardiomyopathy. Why do some women present with this syndrome? This is because some women, they have underlying genetic predisposition, and I will come to detail later on. And second hit is that there is vascular insult by antivascular or hormonal effects of late pregnancy and early postpartum period. This slide is very important because it will show what is the action of prolactin. So this is the pathogenesis in patients who are genetically susceptible. In them, the cardiomyocytes, when they have oxidative stress, they release cathepsin D, which causes prolactin to break down into 16-kDa prolactin. Now this is very important because this is toxic to the endothelial cells. Also, this KDA prolactin causes release of some other factors such as microRNA 146A, and this causes cardiomyocyte apoptosis and death. So because of increased prolactin, prolactin is seen in second half of pregnancy and the early postpartum period. This is the reason why bromocriptine treatment has now been shown to be effective, because it will reduce the level of prolactin. Also, why is it associated with hypertension and preeclampsia? Because placenta in the second half of pregnancy secretes this soluble FMS tyrosine kinase 1, which is toxic to the endothelium, and this causes reduction of vascular endothelial growth factor, and this is the reason why. Can I have some attention, please? Thanks. So this is the reason why, because of the increased prolactin and the soluble FMS tyrosine 1, this level is increased, and this is the slide for the pathogenesis of cardiomyocyte apoptosis death, and this is the reason why peripartum cardiomyopathy occurs. So the clinical presentation will be that of heart failure, whatever symptoms of heart failure are there, dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, cough, especially on lying down. Some patients may present with cardiogenic shock or arrhythmias or arterial thromboembolism. Which is the time of most common presentation? Most patients present in the first month after delivery, but considerable number of patients will present in the late antepartum period. Diagnosis is a diagnosis of exclusion. All congenital heart disease or a history of cardiomyopathy, all that has to be excluded on history. And on physical examination, if the patient is tachypneic or tachycardic, or there is symptoms of right-sided heart failure, for example, the JVP is raised or there is pedal edema, or any other signs of heart failure will be there on examination. Embrace report, which is the report from UK, they have said that there are some signs which should be taken as red flag signs. Now, whichever patient has these signs, it is indicative of cardiac disease and should always be investigated. What are these signs? Tachypnea. If any pregnant patient or in the postpartum period has tachypnea, or she has chest pain, or there is persistent tachycardia or orthopnea, these are red flag signs, and these always have to be investigated, and we should not take these symptoms lightly because they are indicative of cardiac disease. Investigations include ECG, chest X-ray, blood tests such as C-reactive protein and CBC. Why? Because they are inflammatory markers. But most important is the brain natriuretic peptide and the N-terminal pro-BNP, which are usually raised. Troponin T may be raised, although most of the times it is normal, and if troponin T is raised, then the prognosis is worse. This is a very simple flow chart for investigating a suspected case of acute peripartum cardiomyopathy. Whichever patient presents with shortness of breath towards the end of pregnancy or postpartum, we have to perform a BNP or NT-proBNP. This is easily available test, and we have to do an echo. If the BNP or NT-proBNP is raised and the ejection fraction is less than 45%, there is a very high chance of peripartum cardiomyopathy. On the other hand, if the BNP is normal or the NT-proBNP is normal and ejection fraction is more than 45%, we have almost entirely ruled out postpartum cardiomyopathy. So this is a very simple flow chart for diagnosis of peripartum cardiomyopathy. Echo is the most useful form of imaging because there is lack of radiation exposure and it is easily available. In that, we see that the left ventricular ejection fraction will be less than 45%, which is the criteria for diagnosing PPCM. Sometimes MRI can be done, especially if we are thinking that there is some thrombus in the cardiac chamber, which might not be so much visible on echo. Differential diagnosis, as I said, it is a diagnosis of an exclusion. We have to exclude everything. We have to start with the benign dyspnea of pregnancy. But in benign dyspnea, the dyspnea is mild. There is no cough. There is no frothing from the mouth. and the SpO2 will be normal. The JVP will not be raised. Whereas with severe preeclampsia, eclampsia, there will be history of hypertension in pregnancy, and the edema will be antecedent to the current event, and also on the testing of the urine there will be proteinuria. If there is pre-existing cardiomyopathy, the patient will have a history, we can exclude it from the history. On echo, the ejection fraction is worse in pre-existing cardiomyopathy as compared to PPCM. If there is valvular disease such as mitral stenosis and aortic stenosis, which are the most common valvular abnormalities which are unmasked by pregnancy, how can we differentiate? Because the heart failure due to these conditions, they present in the second trimester, late second trimester. Why? Because the cardiac output is maximally increased during that time. So whatever abnormality is due to increased cardiac output will present during that time. Also congenital heart disease, we have to exclude by history. The patient might know of a congenital heart disease, echo will be definitive. Myocardial infarction will present with acute chest pain. Pulmonary embolism, the dyspnea of pulmonary embolism is more acute, whereas in PPCM, the dyspnea is there, but it takes 2 or 3 days to manifest wholly, whereas in pulmonary embolism, the dyspnea is a very acute onset. Same with amniotic fluid embolism, there is acute onset of dyspnea and there is circulatory collapse, and these conditions can be excluded on echo. Management, of course, if the patient is hemodynamically stable, a salt restriction is very useful. Loop diuretic, we have to take into account that placental perfusion should not be reduced. Beta blockers, especially selective beta 1 antagonist, should be used. Anticoagulation is necessary. In pregnancy, low molecular weight heparin is used, and antiarrhythmic agents can be used. Whereas if the patient is breastfeeding, we have some more options such as ACE inhibitors, which cannot be used during pregnancy, but we can use this in the postpartum period, and they are very useful drugs. Hydralazine nitrates, in anticoagulation we can continue with low molecular weight heparin, or we can switch over to warfarin. If the patient is postpartum and she is not breastfeeding, all the new options which have come up, and these are very useful drugs, they can be used. If the patient is hemodynamically unstable, of course, there has to be admission in ICU. I'll just go quickly, but the recent is that there is ancillary support with bromocriptine should be kept in mind. In uncomplicated cases, 2.5 milligram once daily for 1 week, whereas if the ejection fraction is very less, 2.5 milligram twice daily for 2 weeks, but we have to keep in mind that those patients who take bromocriptine will not be able to breastfeed, and also that they have to have anticoagulation because bromocriptine has been associated with thromboembolic phenomena. And of course, this is still under trial. It has not come in any recommendation, but it has been found to be useful. Because the time is short, I'll just quickly go through the natural course and prognosis. 50 to 80% of women with PPCM recover, and most of them recover in the first 6 months. At the time of diagnosis, if the ventricular ejection fraction is less than 30%, or the diameter of the diastolic diameter is more than 6, there is decreased likelihood of recovery. Overall mortality is 10% with optimal management. Prognosis, if the patient has associated hypertension, there is higher rate of recovery because the pathogenesis is slightly different. Breastfeeding, can I just have, yeah. So if the patient is hemodynamically stable, she can breastfeed, but if she is hemodynamically unstable and the left ventricular ejection fraction is less than 45%, breastfeeding should be actively avoided. Subsequent pregnancy, there's 50% chance of further deterioration with mortality rate rising to 20%. And if left ventricular ejection fraction has not normalized, the patient should be counseled not to become pregnant again. Management in subsequent pregnancy is that ACE inhibitors has to be stopped if she is trying to conceive. Early booking, beta blockers have to be continued, anticoagulation, serial scans for fetal growth, and we think of delivering the patient at 37 weeks with vaginal delivery, and cesarean only for obstetric reasons, and anticoagulation will be given for 6 weeks postpartum. Contraception, IUCD is effective and long lasting and there is no risk of thromboembolism, but IUCD has to be fitted in a hospital because there is risk of vasovagal collapse. A combined hormonal contraceptive should be avoided. Tubal ligation can be done, but she will have to be anesthetized, which will be a problem. To conclude, PPCM is an uncommon but serious disorder affecting otherwise healthy women in reproductive age. Increasing incidence is due to advancing maternal age, multiple gestation and obesity. Alertness for red flag signs indicative of cardiac disease should be kept in mind. And apart from bromocriptine, no other treatment specific for PPCM is yet in use. Thank you.
Thank you, Dr. Prachi. You have explained the topic very beautifully. You have covered each aspect of it and beautifully explained the role of prolactin, because this condition is very difficult to diagnose in pregnancy because the symptoms overlap. So we have to be very alert, particularly when patient presents at the time of late pregnancy or just after delivery. Patient presents with these symptoms. We have to have this condition in our mind. Thank you.
Our second speaker is no one, our beloved Dr. Rajni Sharma, Dr. Professor Rajni Sharma Madam. She will speak on uterine inversion.
I want to add few words for Madam. Madam is very humble and down-to-earth person. I had the opportunity to work with her in HIV committee. So welcome, ma'am.
Very good morning to all. First of all, I would like to thank organizer for giving this opportunity to me, and thanks my chairperson for sweet word, and thanks to August gathering in the hall. Today I am going to discuss about uterine inversion, very urgent emergency in obstetrics. Uterine inversion, which involves the collapse of the fundus of the uterus into the uterine cavity. It is an extremely rare life-threatening obstetric complication. Incidence 1 in 2,000 to 8,000. It usually occurs as a result of mismanaged third stage of labor, involves premature contraction prior to placental separation, with uterine atony and relatively untrained personnel. Fourfold increase noted in the incidence of acute uterine inversion associated with vaginal birth after the introduction of active management of third stage of labor. Other risk factors associated the uterine inversion includes uterine atony, fundal implantation of morbid adherent placenta, manual removal of placenta, precipitated labor, a short umbilical cord, pedunculated uterine leiomyoma, and connective tissue disorder. This condition may result in very high mortality rate if not promptly managed. Here, I am presenting 4 such cases encountered in my professional experience along with their management. Case number 1. A 26 years old, previous to delivery with 2 live issues, referred to our hospital at 2 hours postpartum in shock. Patient had a vaginal delivery at home conducted by village untrained birth attendant Chaman. Patient had uterine inversion. It was diagnosed by doctor when she was taken to nearest hospital. An unsuccessful attempt to reposit the uterus was made at that hospital. The vagina was packed with the roll gauze and referred to our hospital. On admission, blood pressure 84/54 millimeter mercury, pulse rate 140 per minute, with 99% oxygen saturation. PA finding uterus around 16 weeks with palpable depression at the fundus. PV after removal of vaginal pack, uterine fundus was felt in vagina and cervical ring felt well above the level of fundus. This confirming the diagnosis of third degree inversion under general anesthesia. Manual reposition of the uterus was done, given in below diagram. Uterine tonic agent, intramuscular and intravenous oxytocin or intramuscular carboprost were given, following which the uterus becomes well contracted. Patient received 900 PRBC along with the intravenous fluid and noradrenaline during a simultaneously resuscitation carried out by the anesthesia team. The patient also received higher antibiotic for 6 days. The post-procedure period was uneventful. The patient was discharged in a stable condition on 7th post-operative day with the post-operative advice to report back to hospital for in case of reinversion, fever and vaginal bleeding, secondary PPH. My case number 2, a 28 years old P3L3 was admitted for safe confinement in our hospital. Patient had a spontaneous vaginal delivery. A baby was delivered. Uterus was not palpable per abdomen. A big mass was noted in vagina, which revealed to the uterus with placenta and PPH leading to shock. Quick resuscitation was done and uterus repositioned manually. Placenta separated spontaneously during the process of reposition. Bimanual massage was done. Oxytocin 20 units in infusion was given. Injection methargine and injection PGF2 alpha were also given. Uterus was still not contracting and hemorrhage continues. So condom tamponade was done. Uterine contraction was maintained by oxytocin drip for 12 hours. Patient was kept under antibiotic. After 48 hours, catheter deflated slowly and then removed. Uterus was well contracted and there was no bleeding per vaginum. She receives 5 units of PRVC and FFP. The post-procedure period was uneventful and patient was discharged in a stable condition on 7th post-operative day with the same post-operative advice as case 1. Case 3, a 25 years old second gravida delivered and a live female weighing 3.5 kg in our labor room emergency. After delivery of baby, bolus oxytocin 10 units intramuscular was administered. Uterine contraction was noted and gentle cord traction was applied in order to deliver the placenta with slight cord traction. Complete inversion of uterus occurred with the placenta firmly attached to the uterine fundus. Immediately reversion of uterus was done with placenta attached by gradually rolling the lowermost part of posterior edge of the uterine fundus, thereby everting the part that invert last. It was done under anesthesia. IV syntocinon infusion given. IM methargine was also given to maintain uterine contraction. Then after manual removal of placenta was gently done when uterus was well contracted. SOX was managed with 3 PRBC along with IV fluid. The post-procedure period was uneventful and patient was discharged in a stable condition on 7th post-operative day with the same post-operative advice in first case. Case for a case of 20 years old, primipara, with history of normal delivery, conducted by untrained birth attendant nearly 30 hours back in a rural setup. Initially, she had normal vaginal bleeding with slight abdominal discomfort. In next morning, while passing urine, she felt severe abdominal pain and noticed chunks of blood coming through the vagina. She was rushed to a PSC in village, from where eventually she was referred to our institution with the diagnosis of PPH. On admission, patient BP 90 to 60 millimeter mercury, pulse rate 130 per minute. During PA examination, uterine fundus could not be palpated, but cupping was appreciated. PV examination, a speculum examination revealed fresh bleeding and mass of 8 into 10 centimeter inside the vagina, but fundus of uterus was not felt. A clinical diagnosis of acute inversion of uterus was made. Under anesthesia, vaginal manual reposition was attempted, which failed due to tight cervical ring. Then O'Sullivan hydrostatic method was tried, but was also unsuccessful. Finally, abdominal reposition was planned. She was given medical management with blood transfusion and her vitals were stabilized. On opening the abdomen, classic flower pot appearance was visible, which cupping of uterus with tube and ovarage inside the cupped uterus. After successful attempt via Huntington procedure, pulling of the round ligament, Huntington's procedure, the posterior ring of inversion was cut vertically and then uterus was pulled up. Hulton's procedure. Post-operative period was uneventful and the patient was discharged after 10 days with same post-operative advice as case 1. During discussion, during 5-year period, there were 4 cases of uterine inversion at Patna Medical College Hospital, Patna, as compared to vaginal delivery. Very important thing, incidence is much lowering during cesarean section found in this study. It can be classified as acute, subacute or chronic. Inversion diagnosed within 24 hours are termed as acute. Those diagnosed between 24 hours to 4 weeks are termed as subacute, and those diagnosed after 4 weeks are termed chronic. By virtue of degree of inversion, it can be classified from 1st to 4th degree inversion given in diagram. Uterine inversion can potentially lead to hypovolemic and neurogenic shock. Neurogenic shock is very important for during uterine inversion. The diagnosis is usually clinical. Bimanual examination is the first line diagnostic tool wherein a cup of depression is felt at the fundus associated with congested, soft and bleeding Mansi's vagina. On transabdominal examination, transabdominal ultrasonography, a characteristic target sign showing a hypertrophic fundus surrounded by hypocast rim created by the space between the endometrium and vaginal wall can be seen in the transverse plane, and Y-shaped endometrium is seen in the first degree inversion. Now, take home message. Uterine inversion is a rare occurrence with potential life-threatening complication which can be prevented by active and careful management of 3rd stage of labor, MSTL, and avoiding cord traction prior to development of sign of placental separation. Earlier stage of uterine inversion may be confused with prolapsed fibroid or cervical polyp. Prompt management can avert maternal morbidity and mortality. Counseling, very important thing, is counseling about institutional delivery and regular antenatal care among society is very important. Institutional delivery with practice of principles of active management of third stage of labor and improvement in emergency obstetric care service at peripheral hospital, avoiding delay at all level will help reduce the incidence, morbidity and mortality associated with acute inversion of uterus. Thank you for patiently hearing.
Thank you, Rajnidhi. You have given us a very elaborated knowledge of uterine inversion. You have told us that in our PMCH, 4 cases came within 1 year, within 5 years. Within 5 years. Although incidence is less, but our institute is a referral institute, that's why it has come so much. You have told in 3 cases you can able to reposition it, but in 1 case you have to do abdominal operation. And everything you have elaborated very nicely, acute, subacute, chronic, all the aspects of uterine inversion. Thank you very much.
Thank you to us.
Our next speaker is Dr. Bharti Maheshwari Madam. She will speak on feto-maternal hemorrhage. Welcome, Madam.
Good morning, namaste everyone. Greetings from Uttar Pradesh. First of all, respected chairpersons, good morning. First of all, I would like to congratulate whole Patna organizing team for organizing such a wonderful conference on very important topic. And I am appreciating that sessions are going on time. So this is very, important things in conference because my topic was on, have to be on 11 and it is 11. So I will take care. I think that will finish even 2 minutes before the time. I think that is the best thing what we have to do. So in next 12 minutes, I have to speak on feto-maternal hemorrhage. So first of all, good morning, and I have talked all Patna societies and all societies many times during my MTP committee tenure. So before just starting to my topic, I am just giving you thanks for all supports and supporting my candidature of North Zone Vice President election year 2023. So come to feto-maternal hemorrhage. As we all know, that spontaneous feto-maternal hemorrhage is defined as when feto-maternal bleeding with no history of trauma and no clinical histopathological evidence of abruptio. Because as we all know that when there is some abruptio or some bleeding, though we always suspect that the woman can have feto-maternal hemorrhage. But it is spontaneous, sometimes we are not knowing, and frequency and volume of these type of bleeding increases with advancing gestational age, and they are highest at birth. Spontaneous, massive, also called large feto-maternal hemorrhage is less common. Why we are talking about feto-maternal hemorrhage? We all know because if it is acute and massive, it can result in rapid fetal hemodynamic collapse and death. And nowadays we are talking about so much on stillbirth prevention. So there is sometimes silent feto-maternal hemorrhage. It is also a cause of such type of casualties. If feto-maternal hemorrhage is not massive, it is chronic, intermittent, repetitive, it can result in fetal anemia and hydrops fetalis. Over time, depend on the ability of fetus to increase red cell production and compensate for ongoing blood loss. So I have already told you that though many definitions are there, but most specific is when there is more than 20% of fetal blood volume, because this degree of blood loss is associated with fetal morbidity and mortality. If it is there, then it is called feto-maternal hemorrhage. And how we can detect this amount of blood volume? When fetal maternal hemorrhage, it is associated with middle cerebral artery peak systolic velocity, which is more than 1.5 multiple of medium, and this correlates with moderate to severe fetal anemia. So how you can diagnose? When you do the Doppler and you see that systemic MCA it is more than 1.5. If we talk about the incidence, then how it is common? Actually, massive is not very common, and sometimes it is not diagnosed because its clinical features are not very clear. But when large number of Rh negative patients in one study, they are routinely tested for FMH after birth. And the frequency of FMH when it is more than 80 ml range from 1 in 1,146 to 1 in 1,429. So it is around 1 in 1,500 birth is indicated or found. Pathogenesis, we all know fetal-maternal hemorrhage, that what is the role. When there is any time fetal-maternal hemorrhage, there is a formation of maternal antibodies against the fetal red blood cells, and when these transplacental transfer of these maternal antibodies, then they destroy the fetal red blood cells. So clinical presentation is spontaneous massive FMH can occur at any time in pregnancy or at birth, and fetal death may be presenting sign of massive acute bleed. That's why when we talk about in this era about the prevention of stillbirth and managing, so this issue is important. Hydrops or abnormal fetal heart rate, sometimes they are presenting features of fetal-maternal hemorrhage. Clinical scenarios that have led to a diagnosis of massive FMH, they include, this is very important, you must suspect if there is decreased or absent fetal movement, which is the most common presenting symptom of massive FMH, and this is reported by 27 and 54% of patients in 2 different series. Mother is usually otherwise asymptomatic, but symptoms suggestive of transfusion reaction, they occasionally occur. Unexplained neonatal anemia. Second important clinical features, if you some women can have fetal maternal hemorrhage, where the neonatal anemia, you find that massive FMH, they resulting in neonatal anemia, and it is around 1 in 9,000 deliveries. In severe cases, the newborn may be pale and in circulatory collapse at delivery. Lab results showing increased production of red cell precursor, increased circulating reticulocyte count. Yes, these suggest that FMH occurred 1 to 2 days before birth. Third important feature is unexpected fetal demise or stillbirth. Testing for, in such cases, testing for FMH may be a part of evaluation of unexpected fetal demise. Up to 15% of fetal deaths are associated with massive hemorrhage. Causation is supported by FMH more than 20 to 25 ml per kg fetal weight, and especially more than 40 ml per kg fetal weight. Fourth important presenting is non-immune fetal hydrop. If like some, the NIHF may be associated incidentally during prenatal sonography performed per standard obstetrical indication during a workup for decreased fetal movement or abnormal result on antepartum fetal surveillance. Third important thing is the evaluation of NIHF may reveal severe fetal anemia, and if you see the middle cerebral artery flow, then it is more than 1.55, and subsequent evaluation may reveal massive FMH as a cause. Sinusoidal fetal heart pattern. This is also very important clinical presentation or investigation presentation. When you do CTG, you find a sinusoidal FHR pattern, and this may also be associated with hypoxia, acidosis, and asphyxia. And you know about the sinusoidal pattern, how it look like. Sometimes it is called pseudosinusoidal, but there is no consensus on the exact definition of this. So routine postpartum Klinghauser-Betke testing, we all are familiar with this test. This is performed for looking significant FMH prior to anti-day immune globulin stimulation in Rh negative mother. Candidate for FMH testing, massive FMH will only be detected if clinicians are aware of the clinical scenario associated with disorder and test for FMH, what I have already told you. So this is the flow diagram where normally non-immunized mother blood group you do, and mother is Rh negative. If her husband is negative, then there is no need for further evaluation. But her husband is positive, then you have to do ICT at 28 weeks. If it is negative, then anti-T 300 micrograms should be given and delivery at term. But if it is positive, then management as in the immunized mother. Testing for massive FMH is appropriate in the clinical situation when non-immune hydrops fetalis with MCA more than 1.5, sinusoidal fetal heart rate pattern, MCA PCV more than 1.5, fetal demise or stillbirth, or neonatal anemia. So these are the pictures when you can find out in the cases of the fetal maternal hemorrhage. How you can measure the volume of FMH? Two tests are available, KB, Klehor, Bedkit acid elution assays and flow cytometry. We are familiar with this KF test. We know that we estimate the F hemoglobin, and in the flow cytometry this is more accurate test where you can detect the measurement. How you manage such cases? If it is more than 32 weeks of gestation, then you see the MCV, and if it is more than 20% of volume is transfused, then immediately cesarean birth. If less than 32 weeks, then of course you have to measure the FMH and you see the MCA, and if here the transfusion, intra-fetal transfusion has to be done to manage the fetal anemia. So this was the flow chart of the management and how to delivery. Cesarean birth is preferable. Placenta should be sent for histopathological evaluation, although rare massive FMH had been associated with intraplacental choriocarcinoma. If we talk about the recurrence, there is no significant evidence on the base that recommendation of again all tests has to be done, as recurrence is not very common, only 0.5%. So again you have to see the clinical features and have to decide for investigation. So in the last, awareness about the prevention of fetal-maternal hemorrhage, measurement of fetal-maternal hemorrhage amount, identification of fetal anemia and treatment timely, it is the key for good outcome. In unexplained stillbirth or IUD, one should check for this. ABO-RH negative or ABO-RH doping should be done always. It should not be forget before abortion and delivery cases. So thank you for this comprehensive talk on fetal-maternal. It is a large topic, but I think important things are highlighted.
Yeah. Hi. Thank you, madam, for your deliberate and elaborate topic. Madam, one question I have, is there any role of HPLC in detecting this condition? Yeah, because flow cytometry and Klehor-Betke is not available everywhere. So is there any role of HPLC in detecting this condition?
Actually, studies is not documenting, but of course in future we can think that for that. But here the demands of time is that most of the time we are not even aware that we should see for fetal-maternal hemorrhage. So here the things are many things what can suggested, but of course measurement of volume is only the thing where you need the highly investigation like flow cytometry. Otherwise, you can just detect by whatever I have told you, by taking help of ultrasonography, by taking help of CTG and all. Thank you,
ma'am.
Our fourth speaker is Dr. Chaitanya Ganpule. He will speak on immunization in pregnancy and beyond. Of course, it is a very important topic. Every day we have to come across with this topic. Thank you, sir.
Hello. Yeah, good morning all, and thank you, chairpersons. I would like to thank the organizers, Dr. Alka madam, Dr. Pragya, and all the conveners of this Labourcon 2023 for giving me this opportunity to be here today and speak on this very important topic. I bring greetings from the land of Shivaji Maharaj and greetings from my city, Pune, which is also called as the Oxford of the East. I'm going to discuss today about vaccination during pregnancy and beyond. Now, after discussing about the catastrophic events during labor, that's uterine inversion, and talking about fetal maternal hemorrhage, we are coming back to little pre-pregnancy and during pregnancy, what vaccinations need to be done. I'm going to go quickly through what are vaccines, how do the vaccines work, what are the different vaccine preventable diseases, is there a need to vaccinate these women, what are our concerns when we are going to vaccinate these women, and then we are going to quickly go through the different vaccinations which will be done during the pregnancy planning, then the pregnancy, postnatal period, and in all for all adult and elderly women with side effects of vaccination. So as you all know, vaccination is a simple, safe and effective way of protecting our body from harmful diseases before one comes in contact with them. It uses our body's natural defenses to build resistance against the specific infection and makes our immune system stronger. So how do these vaccines work? Now these vaccines are usually live, attenuated or inactive viral or bacterial particles or the toxins which are injected in our body. After injection, they elicit an immune response which produces antibodies against these viruses or diseases. And therefore, when we get infected with these viruses and diseases, these antibodies help us to prevent being infected by these viruses and the bacterial diseases. So what are the various vaccine preventable diseases? There are quite a few. The list is long, but the important ones for us are the cervical cancer, the COVID-19 in this ongoing pandemic, diphtheria, hepatitis B, influenza, meningitis, pertussis, pneumonia, rabies, tetanus, typhoid, and varicella. Those are the ones which are important to us. What are the different types of vaccines that are available? We have toxoids, then we have live virus vaccines, inactivated virus vaccines, inactivated bacterial vaccines, specific immunoglobulins, and then standard immunoglobulins that can be used for vaccination during the planning of pregnancy and during pregnancy. But is there a need for all these vaccinations? Well, the latest WHO data which is published shows that about 1,675 cases of rubella were reported in India in 2021. We all know that rubella infection just before pregnancy or during the first trimester can lead to miscarriages, stillbirths, or birth defects in the form of congenital rubella syndrome, which has cataract, heart disease, hearing impairment, and developmental delays in the infant. Between 96 and 2010, 105,000 cases of CRS were reported globally, and it's very important for us to note that 38% of them were reported from India. 1,240 cases of total tetanus were reported in 2021, and 81 cases of neonatal tetanus were reported in 2021 from India, and this is because of the unhygienic practices which are done during delivery, like cutting the cord with an non-sterile instruments. 1,768 cases of diphtheria were reported in 2021 as per the WHO data from India, and again pertussis, 593 cases of pertussis were reported. So in all, still all these diseases are quite there in our country, and therefore there is a need of vaccination against these diseases. The average coverage which has been done in our country is about 85% for DTP and 87% of rubella, as against 93 to 95% in the United States of America. So there is still a scope for us to improve our vaccination coverage in the childhood and early adolescence before she presents to us for pregnancy planning. What are our concerns? Well, our concerns as obstetricians is that will the vaccination increase the risk of transmission to the fetus? Will the vaccination cause any defects in my fetus? Or should pregnancy be terminated in women who receive vaccines accidentally? We are going to address these questions as we go through the presentation. So the live virus vaccines which are available are measles, mumps, poliomyelitis, rubella, yellow fever. These are all live attenuated, but the effects of these vaccines on the fetus is unknown, and therefore live virus vaccines are contraindicated during pregnancy. We'll start on this note. Vaccination counseling should be a part of pre-pregnancy counseling. History of occurrence of vaccine preventable diseases in the past or previous vaccinations and any allergies to these vaccinations should be recorded in the history taking when the woman comes to us. Rubella, hepatitis B, COVID-19 and varicella vaccines should be given in the pregnancy planning phase in all unvaccinated women. They should be preferably given in the post-menstrual period. Well, most of the women will present to us with MMR vaccination being done in the childhood, wherein we give 3 doses, 9 to 12 months, 15 to 18 months, and 4 to 6 years. Pregnancy should be avoided for 3 months at least after giving the rubella vaccine because it's a live attenuated vaccine. The diagnosis of pregnancy after being vaccinated does not warrant termination. However, MMR vaccination is not recommended during pregnancy as a matter of caution. The minimum interval during the 2 doses of rubella vaccine should be at least 4 weeks. Now, if she is vaccinated with 2 doses in the past, then only 1 catch-up dose is sufficient. But if the first dose is taken before 12 months when she comes to you, then 2 doses are recommended, which should be taken at least 4 weeks apart. What about hepatitis A? It doesn't increase the risk during pregnancy. Possibly there is no hazardous effect on the fetus. It is used in pre and post exposure, and whenever you are having an international traveler. 2 doses are to be given 6 months apart. Severity of hepatitis B increases during pregnancy. Hepatitis B can lead to miscarriage, preterm, neonatal hepatitis, and newborn carrier states. It's a purified surface antigen vaccine. There is no risk of this vaccine to the fetus. It is used for pre and post exposure at the woman at risk. 3 doses are to be given intramuscularly, 0, 1, and 6 months. All exposed neonates should receive the vaccine and the immunoglobulin as well. Human papillomavirus in vaccination should be considered in the age group before she is planning for pregnancy. There are bivalent, quadrivalent, and now nanovalent vaccines that are available. Now 3 doses are recommended in this age group if she has to be vaccinated after 15 years of age. Before that, 2 doses are sufficient. The dosing schedule is 0, 1 to 2 months, and 6 months. If the woman becomes pregnant after the first dose, then the second dose should be deferred. Rest of the doses can be completed after delivery. However, there is no need again to terminate the pregnancy if she has accidentally taken the first dose of HPV vaccination. What about COVID-19? In the background of the ongoing COVID-19 pandemic, it is recommended that the COVID-19 vaccination should be offered in the pregnancy planning phase. 2 doses of the whatever available COVID-19 vaccines should be given. Second dose should be given 87 to 112 days after the first dose. Tetanus and diphtheria vaccination can be considered in the pregnancy planning phase in all unvaccinated or uninfected women. What about vaccination during pregnancy? FOXI recommends vaccination against tetanus, diphtheria, pertussis, influenza, and even COVID-19 during pregnancy. Let's look at it one by one. Tetanus toxoids, 2 doses of tetanus toxoids are recommended, which are to be given at least 28 days apart. It can be given at any time starting from the 2nd trimester, that is 12 weeks onwards. If subsequent pregnancy occurs within 3 years, then only 1 booster dose is sufficient. 2 doses are not necessary. You can replace the 2nd dose of tetanus toxoid with tetanus, diphtheria, and acellular pertussis, that is Tdap, instead of giving only tetanus toxoid. However, regular pertussis vaccination is contraindicated during pregnancy. It can be given anytime between 27 weeks to 36 weeks of gestation, but earlier the better, because it will give us adequate time to maximize the maternal antibody response and the passive transfer of these antibodies to the infant, because the infant cannot be vaccinated up to 2 months at least. So that is the period when the infant is most vulnerable, and that's why this is important for us. If Tdap is not available, then tetanus and diphtheria vaccination can be given. What about influenza? Influenza against A and B is recommended from 26 weeks onwards. So a good practice could be to give Tdap and influenza vaccine together, say at around 26 or 27 weeks of pregnancy. In case of a pandemic, vaccination can be given earlier to protect the mother. Higher incidence of complications are noted during pregnancy if infected with either H1N1 or H3N2, which is on a rise at present. So protection against these should be offered to all pregnant women. Studies have shown that 63% reduction in the influenza infections amongst infants up to 6 months of age who are born to vaccinated mothers. So it not only protects the mother, but also protects infants till the age of 6 months. Rabies is nearly 100% fatal. There is no change in the pregnancy as far as the disease is concerned. The vaccine is a killed virus vaccine. Safety of the vaccine is unknown. Post-exposure prophylaxis is given 6 doses, each case to be considered individually, and there is no role for prophylaxis in pregnancy as far as rabies is concerned. Now there are certain inactivated bacterial vaccines that can be considered during pregnancy. Let's go through them. Pneumococcus, there is no increased risk of the disease or severity of the disease during pregnancy. The risk of the to the fetus from the disease is unknown. It's a polyvalent polysaccharide vaccine indicated in women with asplenia, metabolic, renal, cardiac, or pulmonary disease, and all immunocompromised women. A single dose is given either intramuscularly or subcutaneously. Meningococcus, again, significant morbidity and mortality. Risk to the fetus depends on the maternal disease. It's a quadrivalent polysaccharide vaccine and is indicated in unusual outbreak situations. What about typhoid? Significant morbidity and mortality. It is a killed live attenuated vaccine. It is not recommended routinely. Oral vaccine is preferred over injectable ones. There are specific immunoglobulins that can be used in cases of exposure. Hepatitis B indicated as a exposure prophylaxis. The dose depends upon the exposure, usually given along with the vaccine. All exposed newborns need immediate post-exposure prophylaxis. Rabies, again 100% fatality indicated in post-exposure prophylaxis. Half dose is to be given at the injury site on the deltoid. It is used in conjunction with the killed virus vaccine. Tetanus immunoglobulins, again it has got severe morbidity and mortality. Neonatal mortality is up to 60%. There is no risk to the fetus by the immunoglobulin. It is used as a post-exposure prophylaxis. One dose is to be given intramuscularly, and it is used along with the tetanus toxoid. Varicella, possible increase in maternal pneumonia. Congenital varicella, neonatal mortality, rarely congenital defects are found after use of varicella immunoglobulins. Varicella zoster immunoglobulin, it has got no risk to the fetus. It is used for healthy pregnant women who are exposed to varicella to protect against maternal diseases. One dose is to be given within 96 hours of exposure. It can be given to newborns as well. It is not indicated for prevention of congenital varicella syndrome. Well, she has come to us without any vaccinations. She has already delivered to us. Can we give some vaccination advice to her during the postnatal period? Postnatal period is a very good window for us, which can be utilized for counseling of the mothers to get vaccinated against all vaccine preventable diseases. It not only protects the mother, but also reduces the respiratory illnesses in the newborns up to 6 months of age, and it does so through the transplacental antibodies and the antibodies which are secreted through the breast milk. So what are the vaccinations that are recommended in the postnatal phase? Rubella, hepatitis B, varicella, influenza, tetanus, and HPV vaccines are all recommended in non-immunized postnatal mothers. FOXI recommends vaccination against HPV, tetanus, influenza, diphtheria for women of all ages, adult and elderly included. What are the side effects? These needs to be counseled before giving the vaccines. There could be fever, but usually it's of low grade. Soreness and redness at the injection site, headache, fatigue, and severe allergic reactions can be seen in very few of them. That's at a glance all the vaccines which are used or should be used during or just before pregnancy. To conclude, vaccination should be offered to all women throughout their lifetime. It should be an important intervention in the practice of all obstetricians and gynecologists. All of us should be well versed with the dosing schedule of all these vaccines. Friends, each mother is precious, so is each baby. So let's come together to protect them all. Let us all take an oath today that we will make vaccination a part of our daily practice and be well versed with their dosing schedule. Thank you so much for your patient listening. I'll just go back.
Of course.
Right. So the guidelines say that it should be at least 4 weeks apart. So I feel even if you have given one at say 8 weeks or 10 weeks, the second one can be given at say 26 weeks along with the Tdap. Secondly, about the question that I think so, because there is no limit which has been given in any of the guidelines that it should be given within this time frame after giving the first dose. All the guidelines say that the distance or the time between two should be at least 4 weeks, not less than that. But there is no limit which has been specified anywhere about how much time, more time is bad for exactly. Right.
Sir, I have one question. Government of India has given us TD in pregnancy. And he is telling you give first dose in first trimester whenever patient comes. And after that, 4 to 6 weeks give second dose of TD. Is it?
Yes. So, see, the same question what she has said. So you can give at any time interval. So 4 weeks is the minimum time which they have specified. They have not specified about how later on you can give that.
But as you told, you give first dose of tetanus toxoid and then give 1 dose of TD?
Tdap, yes. Yes. So it's recommended that the first dose of tetanus toxoid to be given say 12 weeks afterwards. Now there are guidelines which are saying that give it as soon as she visits you, the first tetanus toxoid. That's also said in some of the guidelines. But the FOXI says that it should be given second trimester onwards, that is 12 weeks.
All right,
Thank
with
you, sir.
time respect, if we can.
Yes, madam.
Can we take?
There is, if you are giving TD is given to protect the newborn also. If you have given later pregnancy, then only your neonate is protected for next 3 months. And from the 4th month is going to get vaccination itself. So if you are giving early, you are finishing in 20 weeks, the 6 months will pass and your baby who is born will not be protected. Mother will be protected but not the baby. So ideally it should be given in the later stage, 20 weeks and 26 weeks, so or 24 weeks. So at least mother should be protected. So government guidelines are different aim and these are different aim.
All right.
So aims are different for both the things.
Yeah,
Thank
looking
you so
at the
much.
time, I'm interrupting. Sorry for that. And all the experts are here, so I request them to do
If
offline
the,
discussion,
if the
please.
audience goes without this,
All
then
right.
it is of no use.
I respect that, ma'am.
Very true,
All the
madam.
speakers quickly
Very
come forward and collect your certificate and a group picture quickly. We are coming up with the very interesting panel discussion. I see our experts are already all set with lots of energy here. And we got an expert, Dr. J.M. Kannan, who will be joining us, an expert. Okay, last 5 seconds for picture. Quickly, smile. Ma'am, quickly, 3, 2, 1. Okay, 3, 2, 1. Thank you. Okay, let's go for next session, ma'am. Ma'am, photos हम थोड़ा नीचे कर लेते हैं. Wait कर. हाँ, वो वाला डाल दीजिए. Yes. I'm requesting our moderator to please come forward, Dr. Charmila Ayavu and Dr. Shamal Seth, please.
We'll encroach into lunch now. We'll encroach into lunch because the photo session is going on for a longer time. Yeah, we'll make you forget lunch.
Yes, today lunch is kept.
I'm sure you will do it so bad where no one will leave the place.
We'll fight it out now. May I invite the panelists? First, I would like to invite the esteemed expert, Dr. J.M. Kannan, please. The panelist will be Dr. Veena Sinha. May I request my co-moderator, Dr. Shamal sir, to come on.
I'm already here.
Yeah. The panelists, Dr. Veena Sinha, Dr. Chanchal, Dr. Abhilasha, Dr. Swapna, Dr. Mamta, Dr. Renu, Dr. Archana, and Dr. Ananya. We need more chairs, please. Yeah.
Few these sides. Yeah, sure.
I have to see. Hi. I'm seeing Dr. Veena there. Can you introduce yourselves?
One more this side chair. Can we have 1 or 2 chairs this side?
We need 2 more chairs, please. Ma'am, you can take your seat.
Please. This side.
2 more chairs, please. Yeah. Ma'am, your name?
Hand mic's
Abhilasha.
there.
Okay.
One is there. Okay. One hand mic this
But we
side,
have
please.
to see that scene there. Okay.
So we need to rotate this.
Surprisingly, everybody has turned up. We thought only half of them will be there. That's why I didn't put up the names also.
You can see this one?
We need one more chair. No, one more chair, please.
Is this visible to you? Okay. We'll give one more chair.
Can you change that? They need to see also.
Please.
Okay. I will read it for you otherwise. I will read it for you. So Dr. Veena is there. Dr. Abhilasha ma'am is here. Dr. Swapna? Yes. Dr. Mamta? Yes. Dr. Renu? Yes, ma'am. Dr. Archana? Dr. Archana Pathak is there. Dr. Ananya? Yeah. Ma'am, your name? Chanchal. Okay, yeah, sorry. So we have got a full panel. Huh? It's going to be quite interesting.
Full panel.
Note the time for us. You gave us 10 minutes late. So what time should we finish?
40 minutes with a 50% bonus points.
Okay.
So another 20 minutes, 60.
So let me put some request to the panelists. May I have my yeah. Opinions matter, but make it very short and sweet because they are giving us only 40 minutes and you're almost 10 of us. All of us have to speak something. And please agree with me and Dr. Shamal. You disagree with all the co-panelists. We'll be very happy to hear you disagree with each other. It's going to be only opinions.
Absolutely.
And you can agree with me so that I shut up.
No, they can disagree with us as well. No issue.
So this first.
But your patient should not collapse.
Yeah, patient is collapsed. Okay. Mrs. Yes, she's 32 years. She's a third gravida with 3 girls. She delivered at a nursing home at a periphery 13 days back. Baby was admitted in an ICU and she was in the general ward. She was not in any admission. She was just for the baby's sake. She had a history of fever for 5 days. She was taking some medicines on OPD basis prescribed by the pediatrician where her baby was. She came with a history of, she had a history of oliguria and drowsiness after 5 days of fever for 2 days. And when she was admitted in the hospital where I was, she was febrile, unconscious, responding only to deep pain, pulse rate of 130, blood pressure of 140/90, had pedal edema, she was jaundiced, there was diffuse purpuric rash in the lower limbs, abdomen examination said it was soft. Can I interrupt you, Dr. Chaitanya? Dr. Chaitanya, please. So abdomen was soft, there was no tenderness, uterus was well contracted and retracted, she had no neurological deficit. We did all the investigations. It was a complete blood count, cultures done, urine culture done, culture of all clinically indicated sites was done, ABG was done, coagulation studies done, blood urea, creatinine, electrolytes, and liver function tests were done. The reports were this. How many of you will leave the panel now? Blood urea of 88, creatinine 2.7, bilirubin 8, all liver enzymes elevated, blood sugar 116, platelet count 69,000, albumin 1.8, sodium 130, potassium 5.3, HIV and HbSAg negative. We ruled out all the hepatitis A, B, C, D, E, F, G, H, everything we ruled out. Hepatitis, MP smears showed negativity, bleeding time 15 minutes, clotting time 6 minutes, and PT was 41.5 by 12.4. The INR was increased, FDP was negative. So problems, we had renal failure, we had hepatic derangement, we had thrombocytopenia, and we had coagulation derangement. So what are the differential, each one of you tell you what the differential diagnosis will be. One word.
It can be a HELP syndrome.
For you, HELP first. Madam?
It can be acute fatty liver or
pregnancy. Veena?
It can be acute hepatoencephalopathy. And maybe it's a case
probable
of
cause of
going to
probable cause of the encephalopathy hepatic.
Maybe it's eclampsia or
eclampsia you want to know. Okay, ma'am.
Postpartum endometritis is one of the.
So you are thinking of sepsis, more of sepsis.
More of the sepsis.
It can be thrombocytopenic purpura, but chances are less.
Okay, ma'am, yours.
Puerperial sepsis.
Okay, only 2 for sepsis now. Good. 2 of you have agreed now.
Again, sepsis, maybe PKI, as madam has said in the morning.
Jayam madam, you will give the final
if this
opinion.
slide would not have been there, what would have been the diagnosis? Forget about this slide. slide is in front of you, you are telling so much of differential diagnosis. Remove this slide in front of your eyes. Now what is your diagnosis?
No, with your reports. That's what sir wants to know. With that report. They all stick to the diagnosis. Yeah. Dr. Jayam?
85% is sepsis. Other factors come only into 15%. Endometritis is the least diagnosis.
In sepsis, why do you have such a massive liver damage? Why would you have that? That looks surprising, no? Such an extensive damage. And why does coagulation failure happen in sepsis unless it's endotoxic shock? And you don't have platelets falling for sepsis.
Sepsis can damage anybody, and she maybe have some liver derangements earlier that may have led to all this.
She had a perfectly normal delivery.
So delivery may be normal.
No
but
problems during delivery.
she may
no
have,
blood pressure, nothing. Third gravida.
She had fever.
Fever, only 5 days after she was in the ward. So it can be anything, but the management is going to be the same. You're going to stabilize her now. So where will you admit her if it's help? ICU. ICU. Anybody wants to keep her in the labor room or ward? No. What are the principles of management in help?
As all investigations
The
are there.
sepsis team will talk on. You all said sepsis.
Yes, ma'am.
So, but for help, I want the management.
First of all,
Madam, use the mic, and she's in the postpartum state. You have to remember that.
First of all, while managing health syndrome, we will give oxygen, and then fluid replacement will give, and in case of if the
no, what I'm asking, she's in the postpartum state. So will you give magnesium sulfate? That's a question there. You think it's help, but blood pressure is 140/90. So will you give her magnesium sulfate? Because that question always, because everybody puts on your mind, give max self, give max self. So will you give max self?
No, no.
Will
At
not give
this
max
stage.
self. Okay.
At 140/90.
See, there are 3 people who are thinking it's HELP syndrome. So when you have a suspicion of HELP, it's driven into our mind that we give max self. That's what I'm asking.
Yes, I will give
Max self. I've driven her to give max self. Anybody else? All of you will give max self. Blood pressure is high, you will give antihypertensives also. Yes. That coagulation failure is the one which is going to cause problems for you. Mic has to be switched on, I think. Yeah. It's a very low volume mic. Collapsed mic. It's a collapsed mic.
Hello. Actually, in 15% of cases, HELP syndrome usually don't present with proteinuria or hypertension, so it might be the case to prevent the seizures, we should give magnesium
Yes.
sulfate.
See, keep it in mind. You have a suspicion of HELP. It's not a problem. You give her magnesium sulfate because you don't know whether she's going to go through convulsions next. So at least to keep her the neuromuscular passage blocked, just give her max.
At least loading dose of
yes,
max sulfate.
Madam, don't say you say always max self. Don't mention that. We don't give, but we give. You have to say it's a full dose of max self. So coagulation defects are there. So how much of FFP, how much of cryo, how much of the blood are you going to order? Because she's got a very bad coagulation derangement now.
1:1:1.
You're going to for a massive transfusion protocol?
No.
I will go for investigation first, like INR.
INR all is bad. Everything deranged.
Thromboelastography.
You have a TAG in your hospital?
No.
But then when
not
TAG
yet.
is not available, how will you order?
Not.
How are you going to order, I'm asking? Because, see, blood banks are not going to be very helpful to you if you're going to order more than 1 unit of blood. Then they're going to put you in a trouble. So you have to ask at the first shot itself, how much of blood are you going to give this patient? Because you cannot order again, because it's going to take time for them to cross-match and give it to you. So it's better that you order at the first shot. So how much will you order, and what will be the basis for ordering?
Ma'am, we will
1:1. 1:1.
Ma'am, we will go through.
No, massive transfusion protocol is completely different. That's for a patient who's actively bleeding and you want to replace it as fast as possible. This patient is a one who has come with a coagulation derangement. She's not going to have any procedure now. She's but she's deranged. That's what I'm asking. Will you order for blood, and how much blood will you order?
Ma'am, if the hemoglobin is less than 7, then we will order for packed red cells.
10 HB was 10.5.
Ma'am, in this case, we'll order for around 2 to 4 units of FFP along with 1 pack of packed RBC, PRBC. Okay. So it will be
So this is arbitrary, or you have got something going on in your mind which will dictate how many units of FFP and how many units of platelets?
That's a confusing thing there. See, already she's collapsed. You're seeing all the reports there. You're stabilizing her with the circulation, airway, breathing, all that you have done. But now you've got in your mind the platelets and the coagulation factors, which are all very less. She's not going to undergo any procedure for you. She's delivered already. So in that situation, will you order for blood, I'm asking? FDP is negative. Still not into DIC.
We'll be ordering, ma'am. We'll be ordering.
You will order blood. Just for the sake of it, because you don't want her to deteriorate further, you will order for. Will you what I'm asking is a practical point. Will you base it on your fibrinogen level which you get, or will you base it on the bleeding problems which she has? Because she's not having any problems now.
The clinical sign and symptom are more important. And she is showing petechiae, so I won't believe on the...
Petechiae or platelets?
Because the time, it takes time for fibrinogen level to come. I mean, it's not bedside investigation. It will take 5 hours, 6 hours. So by that time...
We also were confused because we are not going to go for any procedure. So, but the intensivist says we'll give blood, the components. So we ordered blood components, and this is what we base it on. At least you replace 10% of the coagulation factors. You will not have, she will not have epistaxis. They will all have epistaxis, and the catheter you put, she will have hematuria. So that's the reason we gave her blood. We gave lots and lots of blood for her, and we based it on her weight. 10 to 15 ml per kilogram body weight was the one we based it on, and these were the targets we kept for her. Platelets transfusion, you will not give, she's not going to go for any surgical interventions, and if it's more than 50,000, you will not give. She is 69,000, so we did not give her any platelets. And suppose she's acute fatty liver of pregnancy, how will the management change now? In HELP, we said we'll give magnesium sulfate, control her blood pressure, manage her whatever problem she has. So we gave her component therapy also. But suppose she's acute fatty liver, will your management change?
They are more prone for hypoglycemia. That should be taken
Her
into
blood
account.
sugar was 116. She was not hypoglycemic.
But then also we'll be keeping glucose, since sudden hypoglycemia is very common in acute fatty
I
liver.
remember that patient so well because she was always using bad words when I went into the ward. She was and she will shout at you, talk with you. She's never used those words in her life, I believe. Hepatic coma. So you may have a report which is saying 116, it may not be true. She is having a hypoglycemic attack because liver dysfunction in AFLP, they will go for hypoglycemia. So it's better you keep her blood sugars normal. And the core treatment will be do a lab testing perfectly for an AFLP. Immediate transfer to a tertiary care. Do not keep her in your obstetric unit and manage her. Aggressive correction of consumptive coagulopathy is a must, and that's why we had to give her component therapy for her. And suppose she does not respond, going for plasmapheresis seems to help in a group of patients. And if she's not responding, you may even go for a liver transplant, which has been done for acute fatty liver. And suppose she worsens in spite of treatment. Remember, delivery is not the cure for HELP syndrome and acute fatty liver. There's much more to go ahead. So for the next 48 to 72 hours, she has to be in the ICU. Do you agree, or how often have your acute fatty livers recovered fast? It's very rare. Very, very rare. Madam, Jayam, madam.
Her liver may be trying to recover, but the other external factors will jump on her.
So that's why.
Look, in HELP, it usually recovers after 3-4 days. If your HELP is not recovering, then think of AFLP. And AFLP takes a little longer, but it usually resolves.
But keep her under control in the ICU. Do not shift her to the ward thinking that everything is fine. Yes. And what is the differential diagnosis of HELP if it's not resolving with your therapy? We had a patient with HELP, we managed her, but even on the 7th day, she was having a low platelet count and she kept on having hematuria. And then she had a bleed in the cerebrum also. And so when you don't have the resolution of HELP with your delivery, with your symptomatic treatment, what are the differential diagnoses you will go ahead with? What are the cases you have seen when HELP is not resolved?
It is, can be a thrombotic thrombocytopenic
You have seen that, ma'am? TTP you have seen. HUS, anybody has seen? APLA, catastrophic APLA can represent like, no. You had? All of you are so lucky.
Only red.
Catastrophic apply I have seen about 35 years ago. But the present treatment of apply is so different than what we have at that time. But still, at that time, 1985, I remember Mallika, she was saved and she came for the next delivery without any problem. So, catastrophic apply is still a continuous problem, and probably nowadays, because of the energetic intensive care management, it is being treated better.
You can have catastrophic APLA, which is a non-resolving HELP syndrome which you have managed adequately, and that's why you need to differentiate between all these four when you are managing HELP. Acute fatty liver, remember the bilirubin levels will be much higher than in HELP. This patient had 8, so probably she's for acute fatty liver. Coagulopathy develops earlier in acute fatty liver. She had more of coagulopathy. Consumptive coagulopathy it is, and it develops before thrombocytopenia. In HELP, it will be microangiopathic hemolytic anemia. That is why she has more of bilirubin, and her thrombocytopenia is very fast. She will drop her platelets very, very fast. Liver enzymes are more ill. This patient seemed to have a combination of both. She had thrombocytopenia as well as a coagulation deficiency. And remember that hypoglycemia is very common in a person with acute fatty liver, and they go for multi-organ failure very, very fast in acute fatty liver compared to HELP. And TTP and HUS is quite rare, but you remember that TTP can happen in the antepartum period, but hemolytic uremic syndrome is more common in the postpartum period. And hemolytic uremic syndrome is usually because of a virotoxin, endobacteria producing toxins, and that's why she has gone for hemolytic uremic syndrome, but that is because of an enzyme deficiency, TTP. So the difference is you can see with the names itself. It will be thrombosis more, thrombocytopenia more in TTP, hemolysis more, uremia, renal symptoms are much more in HUS. But for all the treatment is plasma exchange. You do plasmapheresis, you can bring more. That's why you manage HELP, you think you're delivered and you think she's fine, do not think so. Wait for 4 days, evaluate her again, she's not resolving. Probably that time when you go for plasma exchange, you can bring out, and for catastrophic APLA, it's a very good treatment, plasmapheresis. And TEG, somebody talked on TEG. Do you use TEG? It's actually very good. You can, yeah, ma'am?
No, we haven't used.
You're going to use? Yeah. Future, yes, subs. So this is how TEG is done, and advantages are you can actually deliver an immediate goal-oriented care. You diagnose and you manage, and you'll get your reports very fast in half an hour, and you can ask for components, particularly what all is needed, platelets, how much is needed, all that we will get with the TEG.
Actually, this assess both, even plasmatic and cellular component, both component. And even clot fragility and strength of the clot is
also you will
also
know
measure. So
Is
it's
it
important
available at your
mainly it is
institute?
used
we have a liver transplant unit attached, so we get a report.
Yes, ma'am. Mainly it is used in liver transplant cases.
Cardiac units also.
Yeah, ma'am. Fibrolysis and other fibrinogen added factors.
It's good that you start having it because it gives you so much more information, and it will avoid overusing the blood products also, because blood banks are not so happy to give so much of blood. And she had acute kidney injury, so how will you manage that part for her? Acute kidney injury. Urea creatinine is elevated. So the red alert is always when you have a person who is delivered and has got a urine output less than 0.5 ml per kilogram, that translates to 30 ml per hour. That's why that magic word of 30 ml for a magnesium sulfate toxicity. So less than 30 ml, that means she's having a kidney problem. And this is how you diagnose. How will you manage acute kidney injury?
It's multidisciplinary
Fluid replacement. Ma'am, first fluid replacement. And fluid replacement should be monitored by central venous pressure, so that we can...
You put your CVP line for all your oliguria patients? You do?
No, okay. No. And we will put urinary catheter, urine output per hour. And if not improvement, there is no improvement of after giving fluid, we can give dopamine, ionotropic, vasopressin, and also go for the blood reports. If there is a history of hemorrhages, we can replace it by blood therapy. And there is also some role of loop diuretic furosemide.
but it is
So
slowly.
see, if you adequately
Lasix
hydrate her, you
challenge
can give
taste.
frucimide.
We do Lasix challenge taste.
Only after giving adequate fluid. So this is a flow chart actually. I have not put it as a flow chart. You give 250 to 500 ml of solution of normal saline or ringer lactate. And then after you've given her 1000 ml of this crystalloids, still if your urine output is not good, as you said, you can go for blood or albumin, whichever one you think is needed for her. After adequate hydration, still she is not having a urine output, you can give Lasix 5 to 10 milligram IV. And if in spite of Lasix she is not throwing out urine, then you have to go for your other management. Vasopressors, your dialysis, all that comes into the picture.
Renal replacement.
Electrolytes are very important at that point.
We will also see the hyperkalemia and metabolic
Magni.
acidosis by simultaneously.
And when you're giving adequate fluids and a pulse oximetry showing an oxygen saturation below 95%, it means pulmonary edema started with all the fluids you've given. So you have to be careful when you're administering your fluids also. And this is one flow chart which will help you. When there's an acute kidney injury, you do a renal function test, you do electrolytes, monitor her urine output. If the creatinine is less than 3, maintain her urine output, her input output should be monitored, a daily renal function test should be done. That's enough. But if the creatinine is more than 3, or the electrolytes are showing that there's a hyperkalemia happening, or the output is persistently less than 30 ml per hour, you will need to go for dialysis. Do not keep in your hospital thinking that she will pour out urine the next 6 hours, 12 hours, 18 hours, and then she'll go for total renal damage and you will not be able to recover at all. And if there's fever and collapse, sepsis team.
Sepsis bundle.
Yeah. What are you going to give? If you are suspecting sepsis, what will be your plan of management?
Within an hour, or mostly within 3 hours, send for LDH, blood culture, and start antibiotic.
Lactate is very important. Serum lactate is very important.
CRP and role of procalcitonin is also.
You do it in your hospital, procalcitonin?
It's not done. Not done, but it's a controversial. But it is
Lactate
also
itself, they don't give us the report most of the time. So, but it's necessary.
We will go for the care bundle.
Okay, I'm finishing. Dr. Shamal has to take over. Yeah. So this patient, I'll tell you, we admitted her in the ICU, resuscitation done, blood products, platelets given, almost 24 units of blood components we gave. We gave platelets because she was having hematuria. That's why we gave platelets. Amikacin, Fortum, vancomycin and ufloxacin given. 1 session of hemodialysis. She had repeated episodes of bleeding diastasis, had episodes of oliguria. We managed all that. At the end of it, she had a hemorrhagic infarct. That also we managed. She had persistent thrombocytopenia, but without plasmapheresis, she responded to intravenous immunoglobulin. And we sent her home. I'm happy to say she came for a 4th delivery to me and delivered without any problems, and the postpartum period also was uneventful. I'm finishing on a happy note. Thank you so much, Dr. Shamal. I request you to take.
Because I am not going to finish until and unless the patient is fit to go home after recovery. That's a routine procedure in ICU. They will always do it. So it's not what to be mentioned over here. So I want to compare this panel with a main conference. Inauguration takes place almost at the end of the conference, and there remains only the Sunday sessions after the phase of inauguration. So conference is already over, and I am going to start the inauguration of the panel. Let me have my slides. So can I ask one question? What is postpartum collapse? In a very simple term, what is postpartum collapse?
It is an acute event which involves the cardiovascular, respiratory, or cerebral event, which results in the deterioration of the maternal condition, and it happens during delivery or in the postnatal period.
So it's kind of thing we can define it in any language we are fit to. We feel
this
comfortable.
is acute event involving the cardiorespiratory system and or brain, and resulting in the reduced or absent consciousness.
All of you have come across a case of postpartum
death.
collapse in your practicing career so far? All of you?
Yes.
All of you? So you consider yourself fortunate or unfortunate? Fortunately unfortunate. So that you can face the panel like this. But I'll start with some simple things. What are the causes of this?
First is obstetric
Causes of
obstetric
postpartum
causes,
collapse.
Obstetric
One
and
cause is
non-obstetric
already
causes.
discussed with.
That is
Obstetric and
What are the other
non-obstetric
causes?
Obstetric and non-obstetric causes.
Yes.
First of all, most common is the obstetric cause, that is, it can be due to PPH or septic abortion or inversion of uterus. And after that, if it is not obstetric cause, then we'll go for the search for the cause of non-obstetrical causes like pulmonary embolism and the venous thromboembolism, amniotic fluid embolism.
So it's better to learn from a panel in a conference how to manage and deal with a case of postpartum collapse and pray that you do not face it. But irrespective of your prayers, you were supposed to face some complications if you are doing obstetric practice. Especially one complication which is very common, this is a PPH. It's bound to happen if you are dealing with some obstetric cases in your practicing career. And we are coming to the management options when we deal with a case of PPH. These are another cause, pulmonary embolism. You do not know when it is going to happen and how. It's so dramatic, and in most of the cases it's diagnosed in the ICU only. And this is one thing, very rare to be diagnosed in a life situation of the patient. It's usually, with very few rare exceptions, it is most often diagnosed in the post-mortem. Diagnosis and management, possibly you do not have any option to manage amniotic fluid embolism otherwise. So prognosis is very poor. Cardiac causes we all know, because we very rarely we find a patient collapsing in cardiac causes if it is known already. If a complication is known to you before you treat the patient, it's very easy to manage and handle to prevent. Otherwise, it's very difficult. So these are all theoretical things, but may happen, you never know. Because there is an important case in our city where in spite of giving a spinal drug which should be given, something else was administered and the patient collapsed. So this is the case. Anyone can take. 22-year-old primary gravida delivered a live baby of 3 kg at term, vaginally developed PPH after half an hour. I gave you the cause, PPH. Collapsed with a BP of less than 70 millimeter. Routine resuscitation failed to maintain BP and control bleeding. So this is a postpartum hemorrhage, absolutely. So madam, can you say what are the kind of postpartum hemorrhage you want to deal with? You want to deal with? Specific question to you, it's not general question.
So
you want to deal with? If at all to deal with, what kind of postpartum hemorrhage you want to deal with?
First, I will check whether the uterus is contracted or not, or there is any local vaginal bleeding, or the
Means you want to deal with before the patient is sent to the ward.
That, yes.
That's the best time that you can prevent the patient getting collapsed. But somehow, at that time, it did not happen. There are many occasions patient is having PPH after he has been sent to ward.
Sometimes we may miss that if there is a small retained beads or episiotomy wound, there may be some hematoma is forming, and we may miss.
True.
So we should recheck that is there any thing which we can correct it immediately by our own.
Absolutely right. There is chance of missing, especially when we are practicing at two different places. I have a normal delivery over here. I have conducted it. So fortunately, she has delivered within time. I have finished everything. Patient is sent to what? I have a lab TLH, total laparoscopic hysterectomy in the other nursing home. I'll have to rush. So I didn't check that much, whether there was a cervical tear or not, whether there was an extension of the episiotomy wound or not, or there must be some bit of placental products remaining inside the cavity. So all these things can happen. Now how are you going to manage?
Can I say one word?
Yes, madam. Please take this.
If you have a postpartum collapse, the management is first put your hand on the abdomen. Are you feeling the uterus? Not feeling the uterus? No uterus. Look at vagina. Is there a bulge or something is outside? That is the first thing, after which please proceed with the treatment.
So in normal, what kind of PPH we usually we should have a very low threshold in stamping a patient to be having PPH. Now, which kind of PPH may lead to a patient to collapse?
It can be either due to rupture uterus mostly, as it is within 30 minutes, half an hour after delivery, or inversion of uterus might be there.
How can you suspect rupture uterus? Patient has delivered a normal vaginal delivery.
Yes, she may. Then
Still
maybe
can happen.
She can. If
Yes, I
if
know
she
still
is
can happen.
multigravida or.
But that
previous-
should that be your first thinking, rupture uterus?
No.
Atonic PPH. Atonic PPH.
Absolutely. So that is the commonest reason. So remember 5 T's for causes of PPH. Tone, atonicity, tissue, retained placenta, trauma, genital tract trauma, thrombus, coagulopathy, and turn, inversion of uterus, rightly mentioned, madam. So coming to atonicity, we all know what are the causes. I won't be going into the details of the causes. Let's move on to the management first. Madam, how are you going to manage this case? Collapse. She has collapsed in the ward. Sister has called you. You are just getting ready to go for TLA is there. Now sister has called you. You have gone to attend the patient. Tell me. Just have that case scenario in front of your eyes. And now tell me how are you going to take
Say
it?
tonic PPH or whatever PPH it is, call for help, because you are not going to do it alone. First maintain the ABC and meanwhile diagnose the cause. Madam rightly said, put finger on the per abdominal examination, and if it's flabby, just order for uterotonics, keep massaging. If improving is well and good, otherwise shift to the OT. I think that will be the better to visualize everything and then proceed.
Now, madam, to you. Suppose the patient is in a state, no, you cannot say it collapse, but having PPH. And it's the first strong suspicion whether there is any placental products remaining inside. What do you do?
First, we'll empty the bladder. Then we'll start, we'll put our hand and see if there are clots or not. And we'll do bimanual massage. Also, we'll try to palpate if there are any bits left inside the uterus.
So do you do bimanual examination there in the ward?
Sir, if by the time OT is not ready, then we can do call.
Suppose OT is
after
ready,
call-
then?
Then we'll be shifting to OT and then.
So how many of the panelists would like to do a bimanual examination there in the ward before shifting the patient to OT if the patient is not yet in shock? Any of you? You? No, not there. Madam? 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 No, suppose you are suspecting maybe there is some clots or placental products inside. Sometimes even blood clots, they prevent the uterus from contracting. If you remove the blood clots, maybe uterus will be contracting. So would you like to take the patient to OT and then you will do the bimanual examination? You will do there and then? Anyone, madam? What? What is the basics? No, that's what I am asking. Whether you will do bimanual examination for the removal of the clots there? You can do there, because even if you ask your ward boy to take the patient to OT, it will take 10 minutes. And by that time, patient will beat another 1 liter. So you can do that if the patient is not in shock till that time. Remember that if the patient is almost in shock, better not to do. You first manage the shock, reverse the condition, take the patient to OT, under anesthesia you should explore. So otherwise, all the steps of management. Now you found this is bleeding from atonicity. Your medical methods. First you will try the medical methods of treatment. Yes, madam. You are nodding your head for such a long time. So please answer. So what are the medical methods you are going to adopt?
Sir, first we'll give oxytocin, uterotonic drugs. 40 units started in 500.
You usually do that 40 units in the drink?
Yes, sir.
Forget about this one.
We will give prostaglandin also, and
Also,
Trenex.
which kind of prostaglandin in which route?
Which route? IM route, sir.
IM, yes.
Sir,
F2 alpha.
intramuscular 15
F2 alpha.
methyl PG alpha 2
Yes.
is given. Then we'll give tranexamic acid 1 gram loading dose IV.
And what about other things?
Misoprostol, sir.
Just, what is your routine usual practice after a patient of yours delivers vaginally? Do you give misoprostol preventive doses?
Sir, 800.
800 do you give? In which route? Sublingual or per rectal?
Sir, actually we will give 600 microgram.
600?
But in this case, atonic PPH we give 800.
800 in which route?
Per rectum, sir.
Per rectum, okay. All agree?
And methyl arbutin is
Anything else you want to give extra? Carbetocin at this stage is not going to help you that much. You have given so much of oxytocin already. If you have given carbetocin there, then is the question, suppose you have given carbetocin at the time of delivery, now what kind of agents you are going to give? That can be a question. But if the patient is developed a PPH now, atonic PPH, I don't think any specific opinion from carbetocin at this stage, I will ask for that. Yes, madam, you are going to? Yes?
I told tranexamic is
Please give the mic.
tranexamic is said.
Now, what the last one? The role is lost totally?
No,
Methyl argometrin?
Sir, after oxytocin, we prescribe ergometrin. And after, if ergometrin not works, then we give carboprost. Okay? And then
On what is the contraindication for the patient, we will go for the first option.
Now, if there is a bleeding from the lower segment, then argometrin is useless. Useless. We all know that, but you don't know where from it's bleeding. Now, medical methods fail. Patient is bleeding, you have taken the patient to operation theatre. What is your plan of management?
We will try to prepare for the intrauterine balloon tamponade. अगर still if she is
Slide
bleeding.
not moving.
OT में ले जा रहे हैं तो क्या करेंगे?
Okay.
Yes. We'll surgically we will explore if there is any tear or any hematoma is there. If that is not there, still it's bleeding, a tonic PPH is there, we can go for intrauterine balloon tamponade. If bleeding is controlled, well and good, then otherwise we will go for the surgical devascularization procedure later
Straight
on.
away, devascularization?
Later on. If
No
it
other
won't
step?
respond. If family is complete, compression suture, compression
Please take the
sutures.
mic, madam, please.
we go see the parity. If family is complete, go for subtotal hysterectomy.
Any other step before that, straight away? These days you should not jump to subtotal hysterectomy. It's so, yes, madam?
If family is complete.
Please, even if family is complete, Sir Norman Jeffcott said a woman has the right to menstruate till the menopause. So forget about that. Yes, madam?
We will give compression sutures.
Yes, that is one option, and I believe these days we all are familiar with this procedure. This is so safe. I have got a very low threshold in giving these compression sutures. Even if I think that the patient is bleeding a moderate amount and may bleed profusely later on, I do give compression stitches, and these are very safe. Till date, I haven't found any complication to be happening to any of my patients. I have given compression sutures. So you should always, even if you have not competed with the technique, once you learn it, it's just like car driving. Till you learn it, you will think it's so difficult. Arey baap re baap, kya ho jayega? Gadi accident ho jayega, hum to mar hi jayenge. Same is compression suture. Once you give once or twice, your confidence level will be so much, and it's so easy and so efficient and life-saving for the patient. It's a very useful tool. So before considering all those things, keep those things for the expert ones. Stepwise devascularization, internal iliac ligation, maybe we are not that competent, but compression sutures, you should all be competent enough. This is very simple procedure, at the same time very specific, very life-saving and efficacious as well. So that's the best option. Madam, your option, I want to.
Any patient who has collapsed, thinking of a postpartum hemorrhage, the circulatory replacement with abdominal management is to be carried out. If you are only attempting on giving medical drugs like oxytocin, carboprost, all these things, if you are not looking into this circulatory system, that will collapse. So here is the place where there should be a nurse. That is why you have called for help. The nurse should be going on giving the fluids as it is required, because at least unless you had a bottle of blood in the table, in the labor ward, it will take at least 20 minutes to arrive for a blood. Collapsed patient will lose her brain if you have not managed her within 5 minutes. And if you have an anti-shock garment in your labor room, which is a must in all centers, please put on the anti-shock garments in all atonic PPH patients, which recovers the patient 40%, and she can even survive for 48 hours, even if you are not able to get a bottle of blood. So kindly do not forget anti-shock garments, IV fluids with a 14 and 16 level, they're saying, bore needle, At the same time, whatever the management has been talked about for the abdominal care, please proceed with depending on your expertise and experience. Thank you.
Thank you, madam. Now, any of the panelists, have you ever given a compression sutures? You have?
I do.
I believe all of you. Yes, that's good enough. So this is the second case. I don't know whether we will be going to 5 minutes extra there than a year. Okay. Okay, I will continue. So this is another case. Straight away going on to the major problems, sepsis and intrauterine fetal death. We have enough discussed with the sepsis, you believe. So it's not required how you are going to define sepsis. How are you going to approach the patient? IUFD and sepsis. We do not need history taking at this stage at least. Your diagnosis, septic shock, should be treated in ICU, that much we have discussed. Investigations, we have seen what could have been the investigations in such cases. Line of management. Now, what fluid and what rate? This is very important. This is not the fluid, what is being shown. Fluid is here. So what kind of fluid do you use first in such of cases? Anyone can take up.
Normally crystalloids.
I'll prefer.
You prescribe, give me crystalloids?
No.
Regal acted. Why not colloidals? Why not the colloids?
Because the BP is low.
The free fluid to bind and then.
Yes, absolutely. And whenever you are in doubt which kind of fluid to be given, it's better to give Ringal lactate. Unless the patient is a diabetic one or something like that. What antibiotics?
Broad spectrum.
Fortunately, these patients are treated in ICU. We are not intensive it. We are not critical care specialists. Usually these are taken care of by the ICCU people, and they are always give their antibiotic of choice. And different ICU setup have got different kinds of antibiotic of choice of their setups. So leave it to their hands and do not enter your head into their treatment. And your role will start playing when there is really question of delivery of the patient. Although you are dealing with a patient of postpartum collapse, but this is a patient with IUFD and sepsis. So your role will start termination of pregnancy. We all know what we should do about the termination of pregnancy. That is not the botheration of us because we are dealing with only postpartum collapse. How to terminate, these are the main role we all know. But sometimes, either maybe with the request of the patient parties or maybe it is taking too long time. Have you ever need to do a cesarean section in a dead baby? I believe if not many, at least few of us do need to deliver a patient with dead baby by a cesarean section. There may be several indications. IUFD and sepsis may be different other parameters.
I have done in one case where there was profuse bleeding, unable to manage, and the os was not open. I did cesarean section in IUD case.
But in this case, a patient in shock, collapse, recovered by the ICCU specialist, our friends have made the patient stable at least. Then how much do you want to wait for the patient to deliver vaginally? So my friend has come to stop me over here.
If the patient condition is not deteriorating, we can wait 12 to 24 hours.
So everyone is minding their own business. Plenary is starting. I will also mind something. So thank you very much. I believe we all have covered how to do within a short time with my co-moderator, Dr. Charmila, sitting in front of me. She will come together. We will have a group photo. So before I finish, Nikhil, give me a minute time only. इसको रोकना है. So मेरा आवाज उधर जा रहा है इसीलिए प्रॉब्लम हो रहा था. ये निखिल की बात है. Now this is one appeal from me. Those who do not know me, I was in this city for 5 years from 1990 to 1995. I did my post-graduation from Patna Medical College itself. Used to work in a nursing home over here, just 100 meters from here. And I will be contesting for Vice President of Proxy from East Zone this election year. And I need your full support, blessings, love for the election. Please consider me. Thank you very much. I believe it's a brilliant performance from all the panelists. Thank you very much to all of you. And you go back home with a prayer that you do not face a patient in collapse. You treat the patient that way that you can prevent the patient from getting collapsed for whatever may be the reasons, for whatever may be the complications you can come across. Yes, of course. कौन दे रहा है? देना है ना? मैं दूं? अमिता, ये मौका दे दियो कि मैं सबको दे दूं? निखिल उतना टाइम दोगे ना?
Anti-shock garment is only for referral units. Please forget it. Anti-shock garment is also for in your hospital also. Please understand, even if you are in a tertiary hospital, please put on the anti-shock garment in all cases of atonic PPH.
To all of you, thank you, thank you, thank you. Thank you very much. Thank you. Delivery? Usually, fortunately, these cases deliver very quickly. Just like eclampsia, just like all those things, they usually respond to the drugs very quickly.
Should be the maximum.
Can you give this to me photographically?
मैं आपको पूरा टाइम देता हूँ, 1 मिनट में अनाउंस कर दूँ बस. Please resume back at 1:15. We got Dr. Poonam Goyal's talk coming up at 1:15. So after plenary session, please come back to the same hall. Thank you.
This one is a better choice and this one cannot be used. So beta-methasone injection has two components, that is beta-methasone phosphate and beta-methasone acetate. So we must understand that the phosphate has a half-life of 4 hours, whereas the acetate has a long-acting scenario. So originally when ACS was proposed in 1972, at that time 1:1 ratio of both the salts were used in beta-methasone injection. The clinical combination of two drugs, there is a very complex pharmacokinetics and the half-life of the combination is 14 hours. So that is why we can use it in two doses. Single weight based maternal dose of intramuscular beta-methasone acetate effectively induces the physiological and biological fetal lung maturation at lower dose than the standard care of treatment with the combination of 1:1. So whenever you are using beta-methasone phosphate, we have to use it like in the dosage of dexamethasone, 4 doses, because of short acting. So what happens in India, the salt available is beta-methasone phosphate. It is not the combination of 1 acetate plus beta-methasone phosphate. So what drug we have that has a shorter period of half-life, so we cannot use that drug effectively. That is why either you use beta-methasone, 4 doses like dexamethasone, or you use dexamethasone only. Dexamethasone would be better because uski cost is very less. It is under the DPCC, what they call it, that the government has capped the price of that drug, whereas beta-methasone is costlier and sometimes it is not available. Dexamethasone is available on each and every shop and each and every hospital emergency. So no additional benefit has been demonstrated for courses of antenatal corticosteroid with dosage interval shorter than that. So we don't need to give the accelerated dosing. We just need to give what we are already giving. We have the dexamethasone 4 doses or the beta-methasone 4 doses. Even though pharmacokinetic data show that beta-methasone levels in maternal blood reach lowest level by 12 hours. There were randomized studies also which show that the drug use should be 1:1 ratio. The rescue steroid dose, a single repeat course of antenatal corticosteroid should be considered in women who are still less than 34 or 35 weeks of gestation,
who are at risk of preterm delivery within 7 days and whose prior course of antenatal corticosteroid was administered more than 14 days previously. So the rescue course corticosteroids could be provided as early as 7 days from the prior dose if indicated in the clinical scenario. Regularly scheduled repeated courses should never be used. Whether to administer repeat or rescue course of corticosteroid with preterm PROM is controversial, and there is insufficient evidence to make a recommendation in the favor or against it. Now, do not routinely offer repeat courses of maternal corticosteroids, but take into account the three things: the interval when the first dose was given, what is the current gestation age when you suspect that patient is going to deliver, the likelihood of the birth within 48 hours if happening, then there is no need to give the rescue dose, because 2 to 7 days we say it takes time for the drug to act. Now the Cochrane meta-analysis which says that the repeat dose versus single dose reduces the RDS by 16% and serious health problems in first week of life are reduced by 17%. The number needed to treat for an additional beneficial effect for RDS was 17 with one dose, and the rescue dose if given, then it was 30. So they say there is you have to take the rational decision whether you need the rescue dose or not. Delay in, what is the concerns about the fetus if you are giving this drug? Some people say there is delay in the brain growth and development, but it has not been proved. There is increase in the risk of cerebral palsy, that is also not been proved with the dose which we are recommending. Exposure to multiple courses of ACS to increased rates of aggressive, distractible and hyperkinetic behavior at both ages of 3 and 6 years. That happens because of multiple courses of ACS, not with the dose which we are using. Postnatal treatment of preterm infants with corticosteroids has been associated with increased risk of neurological development. So that was postnatal, not prenatal, the way we are giving. Now, another evidence that Cochrane meta-analysis and numerous studies have shown that there is no evidence of long-term harm in the use of the drug when the fetus is less than 34 to 7 weeks of gestation. MFMU study of repeat course of corticosteroids suggests that 4 or more courses of the drug may cause the development of cerebral palsy. So, no use of giving the drug repeatedly, just one course is sufficient. In rare events, you need to give another course, that is rescue dose. That is single shot, not 4. Now, coming to review of literature, in 6,870 eligible neonates who were delivered, 20% received no antenatal corticosteroids, 21% received partial antenatal steroids, and 40% received antenatal corticosteroids in 1 to 7 days before birth. And 19% received antenatal corticosteroids, which was given to them before more than 7 days had happened to the delivery. The odds ratio was least in neonates who received antenatal corticosteroids between 1 to 7 days before the birth. So this is another study which also contributes to that only, that administration of ANS was associated with an intermediate and rapid decline in mortality, reaching a plateau with more than 50% risk reduction after an administration to birth interval of 18 to 36 hours. Under the assumption of a causal relationship between the timing of antenatal steroid and mortality, a simulation of ANS administration 3 hours before delivery to infants who did not receive ANS showed that their estimated decline in mortality was 26%. So even if your preterm patient is going to deliver, you can, even if have time only to give one dose, whatever it is, just give one dose only. That may give some benefit to the fetus. This is the same study that I was talking when more than 11,000 people were studied, and here they say that there was 2.3% less perinatal deaths when the drug was used, 2.6% fewer neonatal deaths, 4.3% fewer cases of respiratory distress syndrome. And it was also seen that 1.4% fewer cases of intraventricular hemorrhage was there. So all this review of literature proves that the drug which we are using for this antenatal corticosteroids which we are using is definitely beneficial. Not even a single study has given this, that if the drug is used in a rational or the dose is given in guidelines and it is proving any harm. Not even a single study is there. Now, who are the candidates for antenatal corticosteroids? Peri-viable group. There is one data which says that though we recommend the antenatal steroids from 24 weeks onwards, but still peri-viable, depending upon the institution where you are working, if the baby survival rate is good in their neonatal unit, you can even give the drug at 23 weeks onwards. They say that 83.4% to 90.5% difference in the fetal survival is there. So that is very important, that peri-viable, but we need to take consent in these particular patients, whether the family needs resuscitation of such preterm baby, because that may have later implications. I have seen myself, I am doing IVF also, I have seen myself that even after 15 years of marriage, one couple, they had a delivery which was about to happen at 25 weeks of gestation. Our neonatologist was very confident that according to weight everything should go okay. But when the consent they told, that was signed, which told that this complication after birth, then milestones delay and so many things, then they refused to sign. Let us not shift the baby to ICU or neonatal ICU. So we have to take patient's consent also. If she is refusing for that, then there is no need of putting steroids in her system. So now a single dose of corticosteroid is recommended for pregnant women between 24 weeks to 33.6 weeks of gestation, and may be considered for pregnant women who are starting to deliver before that. So one thing I would like to tell, that there is 8 milligram of injection in dexamethasone. 2 ml, we need to give 1.5 ml. 0.5 is to be discarded. It should not be used as the 4th dose. Then late preterm, that means you can use the drug till 36 or 37 weeks of gestation. This is, I think, same, but when the ACS in term, this is RCOG recommendation, it considers a course of antenatal corticosteroids for those undergoing planned CS before 39 weeks of gestation. It was reaffirmed by ACOG also. Even FIGO also says that 38.6 weeks elective cesarean you can give. So special population like multiple gestation, same dose, same thing you can use. Then PPROM, you have to consider that whether the patient is having chorioamnitis and there is leaking, there is no use of giving the drug. Then in diabetic patient, for 5 days her glucose levels will burden you and they will trouble you, so you need to increase the insulin dose by 20% for that 5 or 6 days period whenever you are giving this. So take home message, antenatal corticosteroid must be used whenever we suspect a preterm delivery to happen within 7 days. Best effect 2 to 7 days. Give dexamethasone 6 milligram 12 hourly 4 doses. Even if dose is incomplete, just go ahead and give it. 24 to 34 weeks is the ideal time, but you can extend it to 35 weeks and prepone it to 23 weeks. It can be used with Maxel, which we use for preterm babies as neuroprotector. Rescue dose only 1 dose, and diabetic mothers blood sugar level should be taken care of. Thank you.
Thank you, Dr. Poonam. It was a wonderful talk, taking into account all guidelines. Very wonderfully said, and everything taken into account. No, one thing which I wanted to ask was, one thing which I wanted to ask was that actually, as you said, something new, that betamethasone, you know, phosphate and acetate, which you cleared. That was something which we all have a doubt about. But betamethasone actually causes prolonged hypoglycemia in neonates. So why do we just not give dexamethasone, and why talk about betamethasone also?
Because the dose convenience, that was the only thing I should say that betamethasone came in, because 2 इंजेक्शन लगने हैं, एक आज आपके पास बैठी है, कल वो घर जाके लगवा लेगी. अब she has come to your OPD at 2 o'clock or 1 o'clock or 11 o'clock, she can't get the dose today. आज अगर वो 1 बजे लगवाएगी तो रात को वो 1 बजे कैसे लगवाएगी, unless she is admitted, then it is a different story. So because of the dose convenience, it came into consideration. And we are in the habit of following whatever is happening in the other countries. Na? There they are having different salt. They are having 1:1. So usko dekh ke bhi betamethasone start ho gaya. That was the reason. हाँ. हाँ. हाँ.
डोजेज क्या है, कैसे कितना कितना देना है?
सब पूरा दे देते हैं या बचाने की कोशिश करते हैं. जो ज़्यादा इंटेलिजेंट है वो बचाने की कोशिश करता है. हाँ हाँ. अवेलेबिलिटी बिल्कुल, और शेल्फ लाइफ का भी डिफरेंस है. Yes, shelf life का भी
Hello. Which I wanted to ask, because according to RCOG,
Doctor, sorry to interrupt. I just want to announce the lunch break is till 2 p.m. We shall start the next session by sharp 2. Whoever wants to sit and ask questions, they can continue. Yes, it's okay. Yes, you can discuss.
Yeah, because RCOG, they say that if a patient comes to you, because there are many patients who say that even at 38 weeks, if they're going for an elective cesarean section, they say, aap de do, aap de do. तो should it be given 38 या 39 weeks पे कि नहीं देना चाहिए? हाँ, कि दे देना चाहिए. If they want, दे देना चाहिए. Okay.
आपने प्री-वायबल कभी यूज किया है? 24 weeks, 25 weeks. हाँ, हाँ, हाँ. How are you going to save the? Oh, and didn't have nothing, no side effects as such in this.
आपने अगर उससे पहले नहीं दिया तो लीगल इशू है. वो डर लगता है ना कि उससे कुछ हो गया. नहीं, वो अपनी मर्जी से नहीं दिलवा रहा है. आप डॉक्टर आप समझिए. नहीं, उनको समझा के बताना है. हम लोग अक्सर 37 कंप्लीटेड इसके पहले दे देते हैं. हाँ, 37 कंप्लीटेड 38 वाली है. 39 तक आ गया. आ गया है ना.
Hello. We are starting the post-lunch session within next 2 minutes. Hello. Let's get started with our next session. And for the session, I would like to request our chairpersons, Dr. Kalyani Singh, Dr. Madhu Sinha, Dr. Roma Yadav, and Dr. Charu Modi to please join us on the dais. Now I would like to request our chairperson to please introduce our first speaker, Dr. Nibha Mohan.
Now, after a very good afternoon to all of you. At the outset, I would like to thank the organizers for giving me this opportunity. We have 3 speakers for this session, and we have a very brilliant speaker, Dr. Nibha Mohan, is with us. Dr. Nibha Mohan is a consultant gynecologist in Patna, and may I request Dr. Nibha Mohan to please start your deliberation. Thank you.
Thank you so much, chairpersons. At the outset, thanks to chairperson of this conference and chairperson scientific committee for this opportunity.